launching that Speg as a promising functional imaging tool within neurology. Also, technological advancements over the past three decades, such as improved gamma camera detector sensitivity, iterative reconstruction algorithms, and refined radio tracer chemistry, has significantly enhanced image quality and diagnostic accuracy. The introduction also of a hybrid spectroscopy system has facilitated anatomical correlation and improved localization. Those milestones collectively contribute to increased adoption in clinical practice and integration in standardized protocols. Leading organizations, including European Association of Nuclear Medicine, Society of Nuclear Medicine, the Movement Disorders Society, and American Academy of Neurology, have incorporated that Speg recommendation within diagnostic guidelines for Parkinsonian syndromes since the early 2000s. Its recognition as a supportive biomarker has improved acceptance in routine clinical workflows, with a consensus statement emphasizing its role in tough cases and differential diagnosis. Recent guidelines also note appropriate use criteria to optimize clinical utility and cost effectiveness. Recent studies underscore the enhanced diagnostic accuracy of that Speg when combined with clinical scoring system and emphasize its predictive value in prodromal Parkinson's disease stages. Meta-analysis reveal pool sensitivities of up to 94% and specificities around 9% in differentiating Parkinsonian syndromes. Additionally, longitudinal investigation highlight its utility in tracking disease progression and treatment response, facilitating improved patient management. Greece was among the early adopters in Europe to implement that Speg imaging, initially at a few centers in Athens, focusing on neurological disorders. Over the years, service availability expanded nationwide, supported by training programs like this for nuclear medicine specialists and investment in Speg systems. This growth aligned with rising Parkinson's disease diagnosis rates and increased demand for supportive diagnostic tools. Our department has conducted over 15,000 DAT Speg studies since 2007 and currently approximately more than 120 exams per month, ranking among the highest volume centers worldwide. Quality protocols and multidisciplinary analysis ensure high diagnostic yield. Our goal is to deliver the best results for our clinicians, of course. Now, novel tracers with improved binding affinity and faster kinetics are under development, aiming to reduce scan time and radiation dose. Simultaneously, hardware innovation, including CZT detectors, enhance sensitivity and spatial resolution while enabling smaller portable Speg systems. Those advances collectively pave the way for broader accessibility and improved patient comfort during image processing. Beyond Parkinsonian disorders, that Speg is increasingly explored for applications in neuropsychiatric conditions such as attention deficit hyperactivity disorders, ADHD, Huntington disease, and drug-induced dopamine system changes. Research also investigated its role in early detection of dementia with Lewy body, contributing to differential diagnostic from Alzheimer's disease. Those expanding indications highlight the modality's versatility and evolving clinical impact. Future developments aim to improve quantitative accuracy via advanced reconstruction algorithms and standardized image protocols, reducing this way inter-center variability. Also, development of quicker, low-dose image protocols will improve patient throughput and safety profiles. AI and machine learning show promising capability to assist in automated image interpretation, pattern recognition, and quantitative analysis of that SPECT scans. Early stage studies demonstrate improved diagnostic accuracy and reproducibility, offering tools to support clinical decision making. Integration of artificial intelligence could also enable personalized image biomarkers and predictive analytics, transforming patient management pathways. As precise medicine advances, that aspect is expected to play a crucial role in tailored therapies based on individual dopamine transporter profile and disease phenotypes. It may facilitate early investigation, monitor therapeutic efficacy, and guide the pharmacological strategies in Parkinson's and related disorders. Its integration with genetic and clinical data could redefine neurological diagnosis and enable optimized, personalized based care. And in summary, that SPECT imaging has evolved significantly from its early research roots to become a vital tool in neurological diagnosis. Advances in technology, radio tracers, and artificial intelligence integration are expanding its clinical utility and accuracy. Looking ahead, that spec holds great promise for personalized medicine and improving patient outcomes in neurology. Thank you very much for your attention. Okay, now we continue immediately with Dr. Leonardos Athanasios. He's an excellent, my opinion is from the best in Athens and nationwide neurologist. It's an honor for us to be here, and I give you immediately the speech.
Thank you, Lucas, for the kind introduction. It's my honor to be here amongst specialists of not my specialty, amongst nuclear medicine specialists, and it's rather tempting to be here with you, trying to provide some clinical information concerning the diseases I deal with in my routine practice. So, could I have my presentation, please?
Ποια είναι?
Leonardo Swan.
Ποια είναι από αυτές? Εδώ. Δίπλα. Όχι, όχι, εδώ. Ας το κάνω εγώ.
Εντάξει.
Όχι, όχι, μισό λεπτό.
Δεν θέλω αυτό. Εγώ δεν θέλω.
Δεν έχετε...
Δεν θέλω. So, these are my disclosures. And we are beginning with the role of DAT-SPECT in the diagnostic workup of Parkinsonism. According to the formal EMA indication, DAT-SCAN or DAT-SPECT in general is indicated for detecting loss of functional dopaminergic neuron terminals in patients with clinically uncertain Parkinsonian syndromes in order to help differentiating essential tremor from idiopathic Parkinson's disease, multiple system atrophy, and progressive supranuclear palsy. DAT-SCAN is unable to discriminate between PD, MSA, and PSP. By definition, the role of DAT-SPECT is not to confirm the diagnosis of Parkinson's disease or other clinical syndromes in patients about whom there is no diagnostic doubt. If a patient fulfills the United Kingdom Parkinson's Disease Brain Bank criteria, the famous UK PD-BBC for Parkinson's disease, no further tests are usually necessary. The diagnosis of PD using the UK PD-BBC has a high degree of clinical accuracy when compared with subsequent pathology evaluation. Similarly, if the clinical picture is clearly characteristic of essential tremor or dystonic tremor, no further diagnostic tests are usually required. So if things are so simple, why are we here today? First of all, let's have a look on this famous UK PD-BBC. We have 3 steps in our attempt to diagnose in a clinical approach a Parkinsonian syndrome. Step 1 requires bradykinesia. My mentor, Stanley Fan, used to say that Parkinson's disease is bradykinesia. You cannot have Parkinson's disease if you don't have bradykinesia. And then one of the 3 following criteria: muscular rigidity, stiffness, rest tremor, and postural instability. Postural instability not caused by primary visual, vestibular, cerebellar, or proprioceptive dysfunction. Then we have step 2 with a list of exclusion criteria. And then step 3, the famous supportive, positive criteria for clinical diagnosis of Parkinson's disease. We need 3 or more of the following to support our diagnosis in combination with step 1, in combination with bradykinesia and one of the 3. It's the famous acronym TRAP. T for tremor, R for rigidity, A for akinesia, and P for postural impairment. But remember that TRAP is always a trap. So the supportive criteria is unilateral onset, the presence of rest tremor. We have to deal with a progressive disorder with persistent asymmetry affecting site of onset most if we are dealing with idiopathic Parkinson's disease. We require an excellent response to levodopa and the side effects from the longitudinal use of levodopa, the severe levodopa-induced chorea, the famous dyskinesias. We have to prove a positive levodopa response for 5 years or more and a clinical course of 10 years or more. So let's see how accurate is this clinical diagnosis of Parkinson's disease. Of course, clinical diagnosis of idiopathic Parkinson's can be achieved with high degrees of accuracy in cases with full expression of the classical clinical features. But this is not our everyday routine. Clinical diagnosis becomes more accurate over time as clinical features evolve and response to medication becomes clearer. However, diagnostic uncertainty remains in early disease with subtle or ambiguous signs. And interestingly, in patients with early suspected Parkinsonian syndrome, the clinical diagnosis changes over time to come in agreement with the imaging results rather than vice versa. So we have numerous clinical studies suggesting a substantial PD diagnostic error later in the disease. We had to revise the initial clinical diagnosis in the 1/3 of the patients in 44 out of 122 cases after a mean of 3.4 years. It's not something we can overlook. So, which are the diagnostic difficulties in making a clinical PD diagnosis? First of all, when we are dealing with bradykinesia, we, Parkinsonologists, refer to the sequence effect. It is, when we order this finger tapping, we have to prove a progressive decrement. This is the real bradykinesia for us. So this assessment of fatigable bradykinesia, the sine qua non of the UK PDBBC, can be sometimes particularly different in patients with tremor. It is also clear that many Parkinsonian features can be seen in cases of the so-called benign tremor. I'm going to refer to it later. So due to this considerable overlap in clinical features between some benign tremor cases and cases with tremulous Parkinson's, there is a tendency to overdiagnose Parkinson's disease in uncertain Parkinsonian cases at baseline. Also, one of the crucial clinical features in Parkinson's disease, the reduced arm swinging while walking, is also a reported feature in cervical dystonia. So, even the most rigorous application of the UK BTBBC is subject to interpretation that could lead to diagnostic errors. Another famous supportive criteria is this medication response to levodopa. It is widely accepted that if a patient responds adequately to a treatment trial of levodopa, the patient response is confirmatory of the proposed Parkinson's disease diagnosis. But nowadays, acute medication challenges are not necessarily straightforward. Indeed, in NICE guidelines, even since 2006, we did not have a recommendation of using acute dopaminergic challenge in informing the clinical diagnosis in suspected Parkinsonian conditions. Instead, NICE supported, even from 2006, the use of DAT-SPECT for differentiating essential tremor from Parkinson's disease. So far, work on defining the magnitude of a significant clinical response is insufficient. If a patient shows little clinical response to a drug, does it mean he does not have this condition or is simply unresponsive to that particular drug? Placebo response is particularly problematic when dealing with dopaminergic therapies, having in mind that dopamine forms part of the so-called reward mechanism of the brain. So, because patients with early Parkinson's disease may exhibit minimal signs, response to L-DOPA or other dopaminergic medication may be difficult to assess, and no benefit may be evident, especially if the most prominent feature is tremor, a clinical presentation, a clinical symptom highly variable in its response to medications and very closely related to stress. Similarly, in essential tremor, the appropriate, medications such as propranolol, Inderal, or primidone, Misolin, commonly have no appreciable effect. To make matters even more confusing, Parkinsonian's disease tremor may sometimes improve with propranolol. So, in some cases, it is when the response to medication is less than expected that diagnostic uncertainty emerges. In these cases, it may not be clear whether the diagnosis is wrong or the patient is simply one of those who does not respond as well as expected. Defining Parkinson's disease, we stated that Parkinsonian tremor is rest tremor. It is when The arm is fully supported against gravity. But although tremor at rest is associated clinically with Parkinson's disease, postural tremor is often noted in Parkinson's disease as well. And the severity of the action tremor, kinetic and postural, is associated with the severity of the rest tremor. Postural tremor in Parkinson's disease, as compared with essential tremor, develops after a longer time. We call this time a latency period, when the limb assumes a horizontal position, becoming again completely supported by gravity. This is the so-called re-emergent postural tremor, and is actually considered to be a form of rest tremor. However, absence of a latency period does not absolutely exclude a diagnosis of Parkinson's disease. So let's have a look at a typical Parkinsonian patient with rest tremor, and now you can see this re-emergent tremor after assuming a new anti-gravity position. We can also notice the facial hypomimia of the patient. He doesn't blink. He has these masked faces, and he's slow, he's bradykinetic. So this is a typical Parkinsonian tremor. In contrary, this is an essential tremor patient. He has a postural tremor. He is not bradykinetic. And also in the famous finger to nose test, we're going to notice that he has a kinetic tremor as well, as he approaches the goal of his movement. We have this goal-directed tremor. So this is a typical essential tremor patient. And this is a very didactic re-emergent postural tremor. Unfortunately, this is not what we usually have in reality. So this gentleman here shows that after a latency period has a postural re-emergent tremor. Concerning essential tremor, classic essential tremor with bilateral and symmetric postural and action tremor of the upper limbs, with or without head tremor, and the absence of any signs of rigidity or rest tremor can usually be easily differentiated from Parkinson's disease. Nevertheless, some essential tremor patients may have a rest component that usually occurs later in the disease course. The cogwheel phenomenon, which is a characteristic of Parkinson's disease, sometimes also appear in essential tremor. And essential tremor is, of course, bilateral, but could be sometimes asymmetrical and rarely unilateral. In addition, we can have some very subtle, very soft extrapyramidal signs, such as reduced facial expression, reduced arm swing, or stooped postures in the elderly. So it's not so clear from the beginning whether we are dealing with a typical essential tremor patient or a Parkinson's disease patient. When these are present in patients with essential tremor, the presence of these subtle, soft extrapyramidal signs may reduce diagnostic certainty. Essential tremor and Parkinson's disease are the two most common tremor disorders we are dealing in a movement disorders clinic. A subset of patients may have a combination of long-standing essential tremor with subsequent Parkinson's disease, the famous ETPD. The literature is inconclusive on the subject whether there is a high risk of Parkinson's disease development in patients with essential tremor, with some reports of no graded risk and other reports of greater than expected risk. There are several lines of evidence from clinical, epidemiological, genetic, and pathological studies supporting a link between essential tremor and Parkinson's disease greater than by chance alone. This uncertainty exists in part because clinical features of tremor sometimes fail to distinguish between ET and PD. So we have this overlap between essential tremor and Parkinson's disease, and in the literature we've had this term, benign tremulous Parkinsonism, which was considered to be a distinct clinical entity characterized by tremor plus minimal progression of other aspects of Parkinsonism. But nowadays, we believe that this benign tremulous Parkinson's is a misnomer. Rest tremor without unequivocal bradykinesia is a syndrome with an undetermined diagnostic outcome and is really a diagnostic challenge. Patients with benign tremulous PD typically present with tremor at rest as the leading diagnostic feature, but tremor may be present during posture and may even have a kinetic component. In the early stages, the typical signs of Parkinson's disease, according to the UK PD-BBC, may not permit a diagnosis of PD, and slowness and absent decrement of repetitive movements, this sequent effect, may not be sufficiently prominent to diagnose bradykinesia. At this stage of the condition, and particularly if it persists for at least 2 years, the MDS, the Movement Disorder Society Consensus Statement on Tremor, suggests that the tremor is labeled monosymptomatic tremor at rest. If a patient has rest tremor but does not meet the criteria for a formal diagnosis of Parkinson's disease, it has been suggested that confidence in the diagnosis can be increased with DAT-SPECT imaging. So monosymptomatic rest tremor has this algorithm for patients with benign tremulous Parkinson's who actually have Parkinson's. The course is not benign as they develop disability during the later part of the disease. For the others, the diagnostic is in error and they do not have Parkinson's disease at all. It would be best to simply describe the syndrome rather than making an uninformed guess about what the patient has. So we should use the term monosymptomatic rest tremor instead of benign tremulous Parkinson. And here, that SPECT may be of value. If there is an evidence of dopamine depletion, the patient is likely to have PD. So the term benign tremulous PD should be removed from the literature, as some of these patients never develop PD, and in those who do, the disease is not benign. We also have this dystonic tremor. Dystonic tremor occurs in a body part affected by dystonia and is often focal with a frequency that varies. The tremor is mainly postural or kinetic. Primary adult onset dystonia can present with an asymmetric rest tremor, sometimes even with the classical pill roll appearance. Decreased arm swing, facial hypomimia, jaw tremor, which are all features of Parkinson's disease, have also been observed in cases of dystonic tremor, but in the absence of true bradykinesia, the sequence effect. Dystonic tremor may be related to the famous subgroup of SWEDS, scans without evidence of dopaminergic deficit, with asymmetric rest tremor resembling Parkinsonian tremor. So lack of true bradykinesia, presence of dystonia, and head tremor favor a diagnosis of SWED, whereas postural re-emergent tremor, true fatiguing or decrement in the movement, good response to dopaminergic drugs, and the presence of non-motor symptoms are in favor for PD. And here, of course, the role of DAT-SPECT is crucial. So let's have this final algorithm. When things are pretty straightforward, if a patient fulfills the UK PD-BBC, okay, we can have a clinical diagnosis of PD. If he does not fulfill UK PD-BBC, we can have an alternative diagnosis such as a classical essential tremor. But when we have a patient with tremor and Parkinsonism, but with clinical uncertainty, whether the patient fulfills the UK PD-BBC, then the use of DAT-SPECT is really of value. So this was my presentation. In the next presentation, I will be able to discuss some clinical cases. I don't know, Lucas, if we're going to answer to questions now or later on.
Yes,
Yeah. Yeah, okay. So thank you very much for your attention, and we'll meet later.
Hear me? No. Thank you, Dr. Leonardos. And now, ναι, εγώ το έχω πατήσει. Thank you. Now, I call Natasha Proku. She's a radiology and radiotherapy technologist in our department, and she will speak us in the procedure of acquiring that SPECT imaging. This is a very important session, I think, because if anything goes wrong in this procedure, then all the physicians to assess the images is without any, let's say, value, exactly. So, Natasha, the podium is to you. Thank you.
Thank you. Good morning, everyone. It's a pleasure to be here today and to have the opportunity to discuss such an interesting topic with you. I do not have any conflict of interest to disclose. I will begin at the base of the pyramid and work my way up. The pathway starts before the patient enters the department. It begins with the initial telephone consultation between the patient and the specialized healthcare professional overseeing appointment scheduling. Initially, the patient is asked to provide their medical history as this constitutes the indication and justification for undergoing the examination, as well as details of current and past medications. On the day of the examination, the patient should be thoroughly familiar with both their medical history and medication use, and should also bring any prior examinations related to the area of interest, SCT, MRI, PET, or SPECT. In order for the medical history to be accurate and comprehensive, the following information should be included. A detailed description of the patient's symptoms, including the side affected, left, right, or bilateral. Relevant medical history includes head trauma, stroke, psychiatric disorders, epilepsy, or malignancy. The patient should also report any medication they are currently taking or have taken in the past, as well as any history of substance use. Once the above information have been obtained, the procedure is explained to the patient, including the administration of the radiopharmaceutical, the waiting times between administration and imaging, the method of data acquisition and its duration. Of particular importance is whether they are cooperative and able to remain still for 30 to 45 minutes. Before patient arrival, medication that may interfere with radiopharmaceutical uptake should be discontinued for at least 5 biological half-lives. The discontinuation should always be carried out in consultation with the referring physician, who will determine whether it is safe to do so. Particular emphasis should be placed on the importance of patient immobilization and the use of appropriate equipment to ensure it, as well as on maintaining a minimal detector-to-patient distance in order to achieve optimal image quality. In cases of non-cooperative or claustrophobic patients, the possibility of performing the examination under sedation with short-acting benzodiazepines should be considered, in which case patient accompaniment to the department is needed. More generally, the presence of a family member or caregiver can help reduce anxiety, improve patient comfort, and enhance the sense of safety during their stay in the department. Contraindications should also be clearly addressed to ensure that the patient is suitable for the examination. These include pregnancy and breastfeeding in women of reproductive age who rarely undergo this examination, as well as known hypersensitivity to the radiopharmaceutical, which is also rare. It should be noted that iodine allergy does not constitute a contraindication to radiopharmaceutical administration. Finally, patients should be informed about radiation protection, all the guidelines, the duration for which these should be followed in order to avoid post-procedural inconvenience and to allow them to plan their schedule accordingly after the examination. Anti-Parkinsonian drugs do not markedly affect DAT binding and therefore do not need to be withdrawn prior to DAT-SPECT, but it is possible that levodopa drugs downregulate DAT expression, and caution is advised in intra-individual follow-up studies. Upon the patient's arrival at the department, a re-evaluation is performed to assess their level of cooperation and ability to remain still throughout the imaging procedure. A detailed medical history is obtained once again, the procedure is re-explained, and relevant prior examinations are collected for comparison or data fusion. Compliance with preparation instructions, including discontinuation of the medication and smoking, is also confirmed. Thyroid blockade is administered at least 1 hour prior to the radiopharmaceutical injection. An intravenous catheter is placed approximately 15 minutes before administration, allowing the patient to be more relaxed at the time of injection. And since tracer binding is not determined by flow effects, the patient does not need to stay in a quiet, dim environment. After the injection, the patient is advised to hydrate and is informed that there is also no dietary restrictions. There are no dietary restrictions. In cases where sedation is required, it is administered approximately 1 hour prior to the start of imaging. And all instructions should also be provided in written form, and detailed guidance should be given to the accompanying person to minimize errors and ensure compliance. Finally, we inform the patient that prior to imaging, they have to void in order to maximize comfort during the procedure and to avoid interruptions. About the tracer, ioflupane is a cocaine analog and labeled with iodine 123 is suitable for SPECT as it has shown high affinity to dopamine active transporters, as Dr. Labraco said at the beginning. It is cleared rapidly from blood, with only 5% remaining at 5 minutes after intravenous injection. Brain uptake is also rapid, as 7% of the injected activity is present in the brain at 10 minutes after the injection, and is decreased to 3% at 5 hours after injection. The primary route of excretion is via the kidneys, as 60% of the injected dose is excreted in urine at 24 hours post-injection, and fecal excretion is calculated at approximately 14%. In a normal patient, there is intense uptake in the striatal structures, which is the desired outcome. Ioflupen is delivered ready for use, although the calibrated amount of activity may need to be adjusted. The administered dose is typically 185 megabecquerels, and it's administered as a slow intravenous injection for over 20 seconds, followed by a saline flush to ensure clearance of the intravenous line and complete administration of the radiotracer dose. Speg should be started when the ratio of striatal to occipital tracer binding is stable, and that happens between 3 to 6 hours after injection of the radiotracer. To optimize reproducibility and to limit inter and intra-subject variability, it is important to choose and standardize a fixed interval between injection and image acquisition. And multiple detector or other dedicated SPECT cameras for brain imaging are to be used for data acquisition. The acquisition parameters: low energy, high resolution or ultra high resolution parallel Hall collimators are the most frequently available for brain imaging. The field of view should include the entire brain and use the smallest possible rotational radius. The typical radius is 11 to 15 centimeters, and there should be a full 360 degrees coverage of the brain. The photo peak should be set at 159 kiloelectronvolts with usually a plus minus 10% window. Additional energy windows may be used for scatter correction purposes. The recommended matrix is 128 to 128. Experimental studies with striatal phantoms suggest that optimal images are obtained when the selected matrix size and size zoom factors give a pixel size of 3.5 to 4.5 millimeters. In general, the pixel size should be 1/3 to 1/2 of the expected resolution, and the slices should be 1 pixel thick. Step and shoot mode with angle increments of 2 to 3 degrees is recommended. The number of seconds per position depends on the sensitivity of the system, but usually 30 to 40 seconds are required, and the imaging time ranges between 30 to 40 minutes. A minimum of 1.5 million total counts should be collected for optimal image quality. Patient positioning is a critical technical step in the imaging protocol. Proper positioning of the patient reduces the likelihood of artifacts due to motion, promotes patient comfort, and most importantly helps interpretation by providing standardized and artifact-free scans. Before imaging, the patient should remove their eyeglasses, earrings, hair clips, or combs and hearing aids. They are positioned supine with their head in a head holder, centered and as straight as possible, and with the vertex of the head at the superior edge of the head holder. If the head holder has extended sides, foam wedges, or even folded seats should be placed between the head and the head holder to stabilize the head. Feeling these materials against their face can also be a reminder for them to keep still. Flexible head restraint, such as a strip of tape across the chin or forehead, may be also used to minimize movement. Patients who prefer to lie with their knees slightly bent may need supporting cushions. The arms should be supported at the sides or in front of the patient. Binding the shoulders may also prevent movement, as well as to reduce the orbital radius of the camera heads. And equally important is emphasizing to them the need to remain still during imaging. It is helpful to explain the immobilization equipment and its role at the time of positioning. We should also inform them that the detector will rotate very close to their face, which is essential for optimal image quality. Decreasing the rotation radius. Shoulder clearance is an important factor to consider in setting the radius. The resolution of an image decreases as the camera distance increases, and positioning the camera head as close to the patient as possible is key to good quality images. This is especially important in that SPECT imaging because we are imaging small structures about the size of a cashew in the middle of the brain. And this is how close the camera head should be to the patient. This is just to highlight how closer the detectors get when the shoulders are cleared, and depicting why a small radius of rotation matters. This image illustrates what happens to image quality when the camera radius increases from 12.8 centimeters to 15 and to 20 millimeters. As the radius increases, the putamen appears shorter, potentially causing the physician to interpret the findings as positive, when in reality the findings are negative based on the 12.8 centimeter image. A small radius of rotation ensures reduced image blurring, clearer structural boundaries, and more accurate representation of the true geometry of the structure. About patient positioning, head orientation is another important aspect in all brain imaging. If head orientation is incorrect or not fixed manually during processing, displayed images may be difficult to interpret, possibly reducing image quality and affecting the final report. Sagittal tilt, forward or backward head tilt, has little effect on image quality in that aspect, as you can see, but it's not the same for lateral tilt, which can cause difficulties in diagnosis. To improve image quality, proper positioning is the most important factor. To correct sagittal or coronal head tilt, the brain can be reoriented by manually adjusting the processing angles. The coronal view is the most useful one to assess and adjust the head tilt. We should remember, though, that patient comfort is more important than the actual orientation of the head, as long as the striatum and occipital cortex are in the field of view. To avoid misinterpretation, technologists need to communicate that positioning the patient was challenging and that the orientation of the patient's head during the processing may be affected. During the acquisition, stay with the patient to watch for movement. Also review the raw data images before allowing the patient to leave. And finally, review the reconstructed images and do not only rely on auto-processing. Speaking of processing, I just want to highlight the importance of using a phantom during system setup. Only through phantom-based calibration can reconstruction be properly optimized and the appropriate number of iterations and subsets be selected. And with my final slide, I'd like to give emphasis to patient-specific positioning. Patient compliance during the examination can be challenging, not because the patient is unwilling to cooperate, but because they may be unable to do so. To claustrophobic patients, instead of sedation, the protocol may need to be adjusted with the camera heads only completing 180 degrees from the back of the patient's head. Also, not all patients can lie flat and still on the imaging table, such as those with severe arthritis, back issues, neck issues, or kyphosis. Positioning these types of patients can be always challenging. On this image, the best way to position patients with kyphosis or severe neck and back pain is depicted. A positioning trick presented by Barbara Graber in an article in the Journal of Nuclear Medicine Technology in 2019. In such cases, adaptation is required. The imaging protocol should be modified to achieve the best possible image quality under the given conditions, because all patients deserve good quality images. And with that, I'd like to thank you for your attention.
Thank you very much, Natasha. And now we continue with Ranu Haralabia. She's a medical physicist and working in Greek Atomic Energy Commission here in Athens, Greece. She has a lot of experience in that aspect, and she will give us, as a physicist, the insights, challenges in that aspect quantification.
Γιατί δεν το βλέπω. Good morning from me too. My name is Anu Haralabia, and today I'm going to talk about the challenges in that Speg quantification. I have nothing to declare. I would like to start by speaking briefly about quantification. Visual analysis is currently the recommended method for interpreting DAT scans. This qualitative assessment demonstrates high inter-observer agreement when classifying DAT SPECT studies into normal or abnormal. However, diagnosis based on visual analysis alone can be challenging because striatal binding changes are hard to detect in the early stages of neurodegenerative disease, especially as Parkinsonian syndrome's conditions often exhibit overlapping neurodegenerative patterns. Semi-quantitative analysis is therefore used as an adjunct to visual analysis to detect small changes in that binding, increasing diagnostic accuracy and reproducibility. Current practice uses softwares to relatively semi-quantify the striata to background ratios of SPECT counts, using the volume of interest or region of interest to obtain what is known as the specific binding ratio. The first stage of the process is the region of interest segmentation. Certain software packages allow automatic placement of regions of interest in the striatum, while in other cases the ROIs must be manually defined by the user. Main regions measured are the left and right caudate nucleus, the left and right putamen, and the whole striatum, which are all reaching dopamine transporters. And the occipital cortex is used as the reference region. After the region segmentation, we have the calculation of SBR. That SPECT quantification uses specific to non-specific binding ratios. The standard metric is the striatal binding ratio, which is defined as the striatal concentration minus the occipital and then divided by it. And the occipital cortex is used because it has minimal dopamine transporter density and is also called background region. The tracer doesn't bind only to dopamine transporters. Some of it stays in blood, accumulates in surrounding tissue, and creates background noise. By subtracting and dividing by the background, the calculation isolates to dopamine transporter binding. Software such as DATQuant can calculate other values like the specific deviation of uptake expressed as a percentage and the Z-score. These values are based on a normals database from the Parkinson Progression Markers Initiative, a comprehensive study of patients with diagnosed Parkinson's disease. In using the data from this study, the generation of an age-matched normals database was possible across a spectrum of ages, providing each individual case a nearly exact representation of their results in comparison to their counterpart from the database. Although the quantification process may appear straightforward, it is not. It involves several limitations that must be considered, and users should be aware of them so that quantification aids interpretation rather than causing confusion, ultimately supporting the correct diagnosis. The first limitation that we are going to discuss is the partial volume effect. Small structures like the putamen, which is 6 to 8 millimeters width, are close to the system resolution, causing underestimation of uptake. The intrinsic detector resolution is 3 to 4 millimeters. However, the final reconstructed resolution is influenced by factors such as collimator type, distance from the detector, and reconstruction algorithm, and is therefore typically higher on the order of 8 to 10 millimeters. The partial volume effect occurs when a structure is smaller than roughly 2 to 3 times the system resolution. The activity from that structure spreads into neighboring voxels and mixes with the background counts, and this produces two effects, the spill out and the spill in. In the spill-out effect, the activity from the structure spreads outside the ROI, causing underestimation of uptake, and in the spill-in, the background counts enter the ROI, causing contamination. In that spec, the spill-out dominates. One solution to better resolution is the point-spread function modeling, which incorporates a model of the system's point-spread function directly into the reconstruction. Instead of accepting blur from the collimator and the detector, the algorithm accounts for it during forward-back projection and iteratively sharpens the estimate. How is this done? In a standard reconstruction, the system matrix maps the activity into projection. With resolution recovery, the matrix includes distance-dependent point-spread function. At each iteration, the following steps are performed. First of all, we have the forward projection. The current image estimate is forward projected using the system model, including the point-spread function. This simulates how a blurred imaging system would observe the current estimate. Secondly, we have the comparison with measured data. The simulated projections are compared with the actual measured projection data to compute a correction factor. Then we have the background of the correction. The correction is back projected into the image space using the same system model, including the PSF, ensuring consistency between forward and backward operations. And finally, we have the image update. The image estimate is updated based on the back-projected correction. More contemporary methods that can enhance the resolution are the advanced reconstruction methods such as Monte Carlo-based and AI deep learning reconstruction. In the first case, the method models photon transport more accurately and improves the resolution and contrast. And in the AI deep learning method, we have the application of a separate algorithm after the reconstruction to make the image look sharper and cleaner. We can also make the resolution better by making our system better, and by that I mean switching to new detector technology such as solid-state detectors. CZT, cadmium zinc telluride, can improve dot imaging mainly by improving how photons are detected and localized compared to traditional sodium iodine scintillation systems. With CZT detectors, we have direct conversion and the removal of the intermediate light states. In the classic detectors, the scintillation light spreads before reaching the PMTs, and this blurs the position estimate, while in the CZT, the charge is collected locally at pixel electrodes, and we have much more precise interaction localization, which leads to a better resolution. Another important limitation in the quantification process is the patient motion. Head movement during acquisition causes blurring and quantification errors. Spectral acquisition is slow. Even small movements can affect the data because each projection assumes the same spatial geometry. If the patient moves, the latter projections represent a different spatial position. This means the projection dataset becomes inconsistent. When the reconstruction algorithm tries to solve the inverse problem, it cannot find a consistent activity distribution. The result is reconstruction artifacts such as blurring, duplication or ghosting, and asymmetric distortions. And as we see in the picture, we have three striata. The motion primarily affects the striatal counts. The blurring reduces counts in the striatum. The automated segmentation algorithms may place regions incorrectly, and motion can mix striatal counts by surrounding brain tissue. In the example, we see that in the first case, the true counts of the striatum are 200, and with the motion they become 170, while the counts of the occipital cortex remain the same. But this leads to a lower SBR of 0.3. So the calculated SBR decreases even though the biological uptake did not change. This can produce false indications of dopaminergic loss. The occipital region plays an important role in the SBR accuracy. The tracer uptake in the striatum is compared to a reference region that represents non-specific binding. The most commonly used reference region is the occipital cortex because it has minimal dopamine transporter density and stable tracer uptake. So the occipital region acts as a normalization factor. Small changes in occipital counts can produce large SBR shifts. A false positive, suggesting dopaminergic loss when none exists, can happen if the occipital counts are artificially high. As we see in the example here, in the first case, the striatum counts are 200 and the occipital 100, while in the second case, the occipital counts are more. So the SBR from 1 becomes 0.67. The striatum did not change, but the SBR dropped significantly. However, it remains the standard reference region because it provides the best compromise between low dot density, anatomical stability, and large enough volume to reduce noise. I would like here to mention the importance of Speg CT in the quantification process, and I will do that by referring to a recent study. The paper asks, can fully quantitative DAT-scan Speg CT using SUV-based measures help distinguish dementia with Lewy bodies from non-DLB cases, and does it add anything beyond standard visual reading? The motivation is that most DAT imaging in DLB still relies on visual interpretation or semi-quantitative ratios, while absolute SUV-style quantification is less studied. We calculated in 74 patients the SUV max, mean, and the relative SUV, which is the standardized uptake value. And this matters because the study is not just doing classic striatal binding ratios, it is testing whether absolute uptake values from quantitative Speg CT are useful in DLB. As we see in the table, the strongest regions were the striatum and putamen, especially using SUV max with an AUC, which is the area under the ROC curve, of 0.83 in the striatum and 0.82 in the putamen, while also maintaining a high sensitivity but a moderate specificity. The code date was a little less sensitive but relatively more specific. Clinically, that means the striatal and putaminal SUV max thresholds are good at catching DLB-like dopaminergic deficits, but they also pick up some abnormalities in non-DLB conditions. The authors themselves say this likely reflects the fact that other neurodegenerative or Parkinsonian syndromes can also reduce dopaminergic uptake, lowering specificity. The final conclusion is that quantitative iodine 123 ioflupane uptake assessment using SUV measures offers clinically relevant diagnostic value for differentiating DLB from other neurodegenerative diseases. I will close by analyzing a bit another interesting study, which is that of SATOP. The purpose was to compare several DAT-scan quantification methods to see which best separates dopaminergic neurodegenerative disease from non-DND. 29 patients with DND and 18 with non-DND were studied. The DND group included 25 Parkinson's disease and 4 dementia with Lewy body cases. The non-DND group included essential tremor, drug-induced Parkinsonism, Alzheimer's disease, and a few non-degenerative other conditions. The authors compared several quantitative approaches, the distribution volume ratio and binding ratio region to occipital ratios, SBR by Bolt's method, and SUV max mean. They evaluated caudate, putamen, and whole striatum measures. The main result was that the best performing indices were ratio-based regional measures, especially the putamen to occipital lobe ratio and striatal to occipital ratio on DFR showed an AUC of 0.96, which were the highest ones, while the code date to occipital ratio on DFR had also a high AUC of 0.946, along with the putamen occipital ratio on BR and the striatal occipital ratio BR of 0.941. The conclusion is that these are the most useful parameters for differentiating DND and can be compared with SBR and striatal SUV. Their comprehensive evaluation improves diagnostic accuracy. Ultimately, the quantification process can be highly valuable because it provides objective metrics such as the specific binding ratio, helps clinicians detect disease at an early stage, increases diagnostic confidence, and supports monitoring of disease progression. However, users must remain aware of its limitations in order to minimize their impact as much as possible. Thank you for your attention.
Thank you for your very interesting speech. So it's now my real pleasure to introduce again Lukas Labrakos. Lukas is a really valuable colleague that contributes essentially to my everyday practice, helping me in accurate diagnosing and managing PD and other movement disorder patients. So it's my pleasure to listen from Lukas the practical, actually, way of processing steps and diagnostic decision making. Thank you.
Thank you. Thank you. So, as Natasha previously said, we have collected all our data, and now what are we going to do with them? Okay. This step is also very important. Again, I have nothing to declare. Now, there are some steps we need to follow in order to achieve maximum results from our report. I suggest all those steps be performed by the same reviewer. First, we will process the data, then we will make a first visual assessment, then we're continuing with semi-quantification, and at the end, we have the final interpretation. So, processing the data. What software should I use? Almost all major medical hardware companies include a complete software package with their system for both acquisition and reconstruction. However, there are also companies that specialize exclusively in medical analysis software. For DATSPECT, DATQuant, and Hermes Medical Solution are among the most commonly used. I recommend that every department be equipped with at least 2 different software programs. If you are starting with DATSCAN, I suggest using both programs for every case to gain experience, and in time you will decide which one suits your needs better. Now, those are the steps we're going to follow in the processing. And we start with motion correction. As Ms. Ganou said, motion correction is extremely important. Because, as she said, we are imaging very small structure. And don't forget that the scan is not a single snapshot. It is built from many projections acquired as the camera rotates around the patient's head. So reconstruction assumes that the head remains in the same position throughout the study. If the patient moves, the projection no longer matches properly, and the reconstruction image may be shown as blurred striata, reduced apparent uptake, or even false asymmetry. This is especially important in that aspect because interpretation often depends on subtle posterior putamen loss and side-to-side differences. So, motion correction starts with quality control. The raw projections data should be reviewed, usually in cine mode, because motion is often easier to detect there than on the final reconstruction images. Also, sinogram and linogram also helps identify sudden or progressive movement. If the motion is minor, software may realign the projection data before reconstruction. The principle here is to estimate how the head shifted or rotated and then correct the projections so that they correspond more closely to a single stable position. This improves consistency in the data and may reduce motion-related artifacts in final scan. As we can see in this example, I don't know, okay, a sudden movement happens in the middle of the scan. In the in and out movement of the head compared to the collimators. Seen here more clear in cine mode, and we resulting this image. It seems to be a pathological DAT-SPEC scan, but if we can see at the left striatum the appearance of two dots, one in caudate and the other in putamen, which it's not quite normal in that scan. After motion correction, we see that now the image shows a most, let's say, correct pathological pattern with a severe decreased uptake on the right striatum and on left putamen, corresponding to an advanced neurodegenerative disease, probably in this case an idiopathic Parkinsonism. Again, another case where we have a more severe motion, again in the in and out head axle, seeing both here in cine and in linogram mode, resulting this kind of image. So again, you will say that maybe this is also a pathological image. So we applied motion correction. As you can see now, the linogram mode, in linogram mode, the slices are all aligned, and we got this very nice and normal image. So take a look of those two images. The differences are enormous. So remember this, motion is crucial. Don't proceed to reconstruction if you not feel confident that the patient hasn't moved at all. Okay. Now, there's also another movement, not in and out position of the head, but lateral, all shift of the head. So here we can see it both in cine mode and in sinogram mode. And we get this nice image that Ms. Ganu also show us. And this is called the kissing coma. I prefer to call it the bat sign, flying upside down. As you can see, it's identically. This movement is very hard to correct it, and we need to reacquire the scan. So we did that, we reacquired the scan, and we got this nice, normal DAT-SPEC image. And we're passing the motion, and it's very important after to set the upper and lower boundaries applied during image reconstruction. Why are we doing that? It's to exclude the salivary glands. They have a high concentration of iodine, and believe me, they will alter your final reconstruction images. Of course, as we can see in these top and down images, the best way to exclude them is during acquisition process. Not capable for all the patient, but it will give you the best results. Masking is also, if you have the opportunity to do it in your software, do it. It reduces background noise outside the head and defines the object boundaries for chunk attenuation correction later, if you do chunk attenuation correction, and also prevents the software from wasting calculation on air background. Now, let's pass to the reconstruction methods, the most important thing here. As we said, the camera doesn't take a picture of a striatum directly. It records counts from many angles. Those are projections, okay? Reconstruction is the mathematical step that turns those projections into tomographic slice. Everything we do later, visual read, quantification, depends on this step. So when you see different looking DAT scans between hospitals, it's often protocol reconstruction differences, not just biology. Remember that. Most that spec use OSEM as an iterative method. Think of it as we start with a guess image. We simulate what the scanner would have seen. We compare to real data, correct the image, and then repeat that process. Because that scan are relative low count and involve small structures, iterative methods usually handle noise and detail better than older analytic methods. Subsets are just a trick we use to make each iteration faster, like learning from mini batches. Now, the biggest practical control is iteration and subsets. More updates generally increase contrast and sharpness. As we can see with 10 iterations, we have a very nice sharp image. But if we push it too far, and we'll get grimy, patchy striata and apparent asymmetries that are just noise. So remember this also, sharper is not automatically better. The best settings are those your department has validated for your camera and workflows. As Natasha said, if you're starting now, always ask for Phantom to make those settings, not just start the exam without testing your system with Phantom. Okay. If also the scan looks unusually speckled, always ask yourself, were the iterations too high? Was the scan low count? Remember that. Now, we can do corrections, okay? Two major corrections affect appearance and semi-quantification. Attenuation correction, where photons are absorbed differently across the head. Then attenuation correction aims for more accurate regional counts. And of course, scatter correction that removes photons that change direction. Again, important thing, corrections can improve accuracy, but they must be consistent with your department's protocol and any normal database used for quant, okay? Filter, it's also very important. It reduces noise, often a Gaussian or Butterworth type filter. If you filter too light, if you filter too strong, you can blur the putamen, making mild loss harder to see. If you filter too light, you may see speckle that might overcall as abnormality. So filter is a real clinical trade-off. Noise suppression versus small structural details. As you can see in the image, there is a big difference from 2 to 25 Gaussian filter. When comparing scans over time or across sites, remember that filter differences can make scan looks more abnormal or more normal than they actually are. Optimization of filter is essential to ensure a consistent and reliable clinical interpretation. Now, after reconstruction, that SPECT images are aligned in 3 orthogonal axes. axial, coronal, and sagittal. This step corrects for patient head tilt and rotation using pitch, row, and yaw adjustment. Proper alignment is essential because the striata must be displayed symmetrically and in a standard anatomical orientation. If alignment is poor, the scan may appear artificially asymmetric or distort, which can mislead visual reading and affect quantitative measurements. So, three-axis alignment is a basic but crucial step before interpretation. And again, the color gradients in dark spec imaging also assist in enhancing contrast between striata and background, improving this way visual discrimination of dopaminergic transport patterns. Common color scales are warm and hot metal gradient. Avoid color with small scale like this in spectrum 10 because they tend to normalize small differences in values so they can fit in their palette and easy produce false positive results. Clinical protocols often recommend standardized color maps to reduce interreader variability. Now we're passing to first visual assessment. In this step, we only need to identify one thing. Is it a normal or a pathological scan? Now, visual evaluation focused on the shape, size, intensity, and on background. Normal striate uptake is bilateral and typically forms this comma shape with a caudate head plus a putamen tail. Symmetry is important. Minor asymmetry can be normal, but not always. The key here is that we can see putamen, okay? We can see also the intense uptake on caudate and that the color line are very well defined with no asymmetries present. Also, a little background is present. Clearly, this is a normal scan, but not quite. We need to do that in every slice from the top of the bottom to check all the slices for asymmetries in shape, size, and intensity. Don't forget that step, okay? And if you can fuse your images with MRI images, then believe me, you'll make your job easier. Now, in this part, I want you to try something. Try to quickly recognize four things as we're moving with some cases. Shape, size, intensity, and background, okay? Let's see them. All those cases are from our department. They're not fake, they're real. All right, so you saw small difference, okay? But the main thing was that all the clues were present. Comma shape, correct size, intensity, and low background. If you have the possibility, again, to fuse the image, you can have more accurate localization, okay? What about the pathological scan? Again, the first thing we have to check is putamen. Is it missing? Where? Left or right? Or both, like in this patient. Okay? Then check the caudate. Is it present? Is the intensity good enough? And then the background. Is it increased or not? And where it is increased? If again you have, I said, the possibility to fuse, you will have better localization in the areas of striata that missing in your scan. That's very important to see it. Okay, we're going to do that again. I'm going to show you a set of pathological scans, and this time I want you to focus on missing putamen coded, intensive, and high background. Okay, let's do that. All right, so you saw differences. Some was very close, yes? You might say that there was the same patient, right? No, none of them was the same. They all had differences, maybe in background, maybe in the intensity. I select them very carefully to appear the same, but they're not the same. Why? To emphasize the need for every detail, background, putamen, intensity of codate, it's very important when you say that this is a pathological scan. In the last scan, as you can see here, the background intensity is so increased that it reaches almost the intensity of codate. This is a total loss of dopaminergic transporters. So, can we get other information from our scan? Of course we can. Like the enlargement of lateral ventricles, like this example. Or better, in this example, as we can see. Or in this example, again. But in this also example, we can see another thing also. We can see the enlargement of subarachnoid space. In this case, maybe due to the hydrocephalus, or diffuse enlargement, like in this case, probably due to atrophy. And of course, we can see old infarcts or other gliotic changes in the brain. Okay, so we're not only evaluating striata, we're evaluating all the brain. Now, with this first visual assessment, you will be able to identify almost 75% of all cases. So, rest 25% will be trickier, reaching the balance loss cases where we have symmetric loss of dopaminergic transporters and needs quantification to find it, okay? So, we're passing to quantification. Most of them have been told by Ms. Hanou. I'd like to say again that there are a lot of companies, DatQuant, BRAS, BASGAN, that use semi-quantification analysis, improve reproducibility with reported inter-software coefficients of variation as low as 5%. As I always said at the beginning, you should use two software for reconstruction and semi-quantification in every patient. Manual ROI needs expert adjustment, but gives precise results, especially when combined with MRI fused images, as you can see in the this upper perfect image. But is time consuming and may introduce interoperative variability. Automated ROI selection ensure a consistent and rapid analysis, enable better compatibility across studies. Comparative studies show automated method achieve equal diagnostic accurate with coefficient of variation under 7%. So, integration of semi-quantitative results improves sensitivity and specificity for Parkinsonian syndromes with diagnostic accuracy reporting up to 9% when combined with visual assessment. Now, we have all the information we need, together with the medical history of the patient, and if we have extra information from MRI or CT, we can proceed to report. That's the easy part. A well-structured report with patient demographics, clinical history, image technique details, visual and semi-quantitative findings, diagnostic interpretation, and recommendation. Clear language and standardized terminology are essential for effective communication with referring physicians. And don't forget, speak with your clinicians to have a feedback of your patient. And I conclude. Thank you very much for your attention.
Thank you very much. It was really interesting, even for me who
Thank you very much. So it's your turn now.
Okay, let's proceed. Okay, perfect. Το άλλο θέλω.
Ναι, ναι.
Μπράβο. Τέλεια.
Άμα θέλετε υπάρχει.
So, I'm going to present two case studies. The first one refers to an 85-year-old male who 2 years ago, before his visit to my office, presented with gait disturbance, loss of balance, and falls. He has been diagnosed by another physician as having PD, Parkinson's disease, so he recommended his physician that he would try some L-DOPA. So he tried some L-DOPA, but without substantial clinical benefit. He had undergone a CT scan which demonstrated small vessel disease, cerebral atrophy, and a ventricular enlargement, period. It was left like this. So his physician, trying to get along with clinical evolutions in our field, conducted an L-DOPA challenge test, which was considered as positive, and then he recommended that the patient should have the latest evolution in our field, the subcutaneous 24 hours per day infusion of produodopa, of foslevodopa, foscarbidopa. So when he came to my office, he had this pump with a substantial rate of 0.34 milliliters per hour in 24 hours a day. And since he had this pump installed, the patient stated clinical deterioration. He was totally disappointed and he was blaming the pump. The pump was responsible for his deterioration. So the examination revealed a patient who was wheelchair bound. He was unable to stand and walk alone. He has a total loss of postural reflexes, so a postural instability. He also presented with akinetic rigid Parkinsonism, more prominent on the left. He had urinary incontinence, and when I conducted a MOCA test to assess his cognitive function, he had a 23 out of 30, so it was marginal but towards pathologic. So I recommended an MRI scan. He did not have an MRI since then, and a DAT SPECT. So this is his MRI scan, and this is DAT SPECT by my friend Lucas here. So Lucas stated that it was a normal DAT scan, normal DAT SPECT. So afterwards, the patients underwent an CSF infusion study, which revealed an increased R-out and increased outflow resistance. It was not just a simple spinal tap, but it's a rather more complex and more sensitive approach conducted by a neurosurgeon. So we had a ventriculoperitoneal shunting with a substantial clinical benefit L-DOPA was gradually tapered and finally discontinued. So his clinical evaluation post this VP shunt, the patient was able to stand and walk without support. He had some evidence of some mild residual Parkinsonism, more prominent on the left, but with normal postural reflexes. His pull test was 0, it was normal. And still his MOCA test was 21 out of 30. So I prescribed him rivastigmine. So let's discuss. Here we have a case of normal pressure hydrocephalus instead of Parkinson's disease, with an atypical clinical presentation. It's not a typical PD presentation. It had very early in the course of the disease loss of postural reflexes and then ambiguous and not very straightforward response to L-DOPA and suboptimal clinical response to L-DOPA. A simple spinal test, and this is another message, is not always able to reliably predict responsiveness to VP shunting. An infusion CSF study, which can calculate this famous R out, can also discriminate normal pressure hydrocephalus from Alzheimer's disease and vascular dementia as well. So we had here a delay in making an accurate diagnosis, which could lead to probably irreversible conditions like dementia, and the patient blaming one of the latest evolutions in our field, the pump, which was not responsible for his clinical state. So I think that that aspect here was really crucial for approaching the patient. So this was my first case. Just a remark about this famous vascular Parkinsonism, first described by Critchley in 1926, but until recently a controversial clinical concept. There are some clinical criteria proposed, such as predominantly lower body involvement. It's the so-called lower body Parkinsonism with bradykinesia and rigidity, with short shuffling gait, with less tremor than idiopathic Parkinson's disease, with poorer L-DOPA response compared to idiopathic Parkinson's, with cerebrovascular disease visualized by CT or MRI scan, a temporal relationship between vascular lesions and the appearance of Parkinsonism, the presence of extensive subcortical white matter lesions, and concluding, distinguish vascular Parkinsonism from Parkinson's disease can be difficult, as vascular lesions and white matter basal ganglia ischemia are frequently present in elderly people. So this was my first case. I think we have time for the second one. This is a very intriguing case. So it refers to a 73-year-old male who came with Madopar, with levodopa benserazide, 1 tablet QID, 800 milligrams per day, a rather high dose. He initiated this dopaminergic therapy 4 months before his initial visit to my office. It was already a high dose of Madopar. So this gentleman presented with rest tremor on his right arm, which was aggravated while walking. It's also a typical Parkinsonian feature. He also had this postural re-emergent tremor I described you earlier on his right arm. He had also jaw tremor. Jaw tremor is also characterized as a cardinal feature of Parkinson's disease. He had also mild rest tremor on the left arm, emerging while walking. He had stooped posture, camptocormia. He has bradykinesia. He had rigidity, prominent more on the left side. He also was really hypomimic. He has these masked faces. So this was the gentleman when he first came to my office. I would say that it's a rather typical Parkinsonian clinical picture, okay? Masked faces, jaw tremor, rest tremor, Okay, so his history. The gentleman reported that his problems began a few months earlier with anxiety and discomfort. He visited a psychiatrist who prescribed some antidepressant, duloxetine, and some sedative, alprazolam, without benefit. He then visited a second psychiatrist, so he prescribed mirtazapine and lorazepam, again without benefit. A third psychiatrist, 1 month later, he prescribed Minitran, perfenazine, amitriptyline instead of mirtazapine, instead of Remeron. According to the patient, at that point, when perfenazine was added, which block dopaminergic receptors, he noticed tremor on the right arm for the first time. Okay, so since then, he reports a rapid deterioration. So the psychiatrist, this third psychiatrist, decides to add biperidine, akinetone, an anticholinergic. So we have a mild improvement of his tremor, of his Parkinsonism. Then comes a fourth psychiatrist 2 months later. The psychiatrist decides to prescribe L-Dopa. Perfect. He stops Minitran and he prescribes Seroxat paroxetine. And this is the patient's examination. Again, the prominent jaw tremor, but with excessive side-to-side mouth movements. He has this postural re-emergent tremor on the right. See how difficult it is to evaluate a sequence effect when we have postural tremor here. Very slow, very rigid. Can you notice something here on his sequence effect? We don't have a real decrement. Okay, just hold this. More rigid on the left side, on the contrary to the tremor side. Slow, rigid, but still not decrementing. His toe tapping. So, what do you think about his clinical diagnosis? I would say Parkinson's, yeah? No? He has many of the Parkinsonian symptoms. He looks very Parkinsonian. Okay. So this is his DAT scan, his DAT SPECT. Not conducted by Lucas, somewhere else. This is the only image I had. So it was given as normal. So I decided to follow the instructions. So L-Dopa was gradually tapered and finally discontinued. I added akinetone, biperidine. I asked for a fifth psychiatric consultation, again mirtazapine and some clonazepam, with a substantial clinical improvement, with less bradykinesia, with normal facial expression, with emergence of tremor only while walking and only on the right arm, with the stooped posture insisting, with jaw tremor accompanied by twisting facial movements, moving mouth from one side to the other. And then I decided to replace biperidine by trihexyphenidyl by Artan, another anticholinergic. And 3 months later, the patient came back with a dramatic improvement. Tremor and camptocormia disappeared, excellent mood, still presenting these side-to-side facial movements. So, unfortunately, 6 months later, this gentleman was diagnosed with leukemia. He never came back to a follow-up. He had required blood transfusions every month, and he passed away. But according to his spouse and his son, he remained free of Parkinsonian symptoms until his death. So, what we had here, I think it probably was a SWED instead of Parkinson's disease, with lack of true bradykinesia, no fatiguing, no amplitude decrement, with prominent jaw tremor, with dystonic posturing of right arm, with suboptimal response to L-DOPA, with response to anticholinergics. Could it also be psychogenic Parkinsonism? Had an abrupt onset with immediate maximal severity, decreased amplitude and variability of tremor frequency during distraction, with spectacular spontaneous remission and these side-to-side mouth movements. I am hesitant about the quality of the DAT-SPECT. But when we are dealing with psychogenic Parkinsonism, which is really uncommon, the diagnosis requires movement disorders expertise. Patients with psychogenic Parkinsonism may have abrupt symptom onset with immediate maximal severity, with spontaneous remissions, with previous history of somatization, with unusual combination of tremors, with decreased amplitude and variability of tremor frequency during distraction, with active resistance to limb movements, with voluntary movements of the opposite hand. A normal DAT-SPECT is suggested to be helpful in discriminating psychogenic Parkinsonism from neurodegenerative forms of Parkinsonism. The same happens with drug-induced Parkinsonism, which is the second commonest form of Parkinsonism after idiopathic Parkinson's, involving dopamine antagonists such as neuroleptics, centrally acting antiemetics, primperan, metoclopramide, and calcium channel blockers, this synarizine, flunarizine. The resulting Parkinsonism may be indistinguishable in clinical approach from Parkinson's disease. Unilateral PD features occur in about 1/3 of patients with drug-induced. It's considered to be symmetric, but in 1 out of 3 patients it could be asymmetric. So the interpretation of the causal relationship between drug exposure and clinical Parkinsonism is complicated by the possibility that the patients with incipient or preclinical idiopathic Parkinson's disease may be unmasked by the exposure to dopamine blocking drugs. And the common clinical practice to withdraw the offending drug is still problematic because recovery after drug withdrawal could take up to 18 months. So, drug-induced Parkinsonism cannot be reliably distinguished from idiopathic Parkinson's only on clinical grounds. So, concluding, patients for whom DAT-SPECT may be clinically useful, patients with clinical comorbidities that mask symptoms or make assessment difficult, drug-induced Parkinsonism, vascular Parkinsonism, tremor of uncertain etiology or suspected essential tremor, psychogenic Parkinsonism, Parkinsonian syndrome not responding to dopaminergic treatment, candidates for DBS, for dream brain stimulation, and patients who deny diagnosis of PD. So these patients might accept treatment if objective data are available. So this is an algorithm. So that is the question, to scan or not to scan. Would a neurologist withhold the trial of dopaminergic medication based upon a SPECT scan? The response to dopaminergic medication is one of the most clinically relevant outcomes in clinical practice. The value of that SPECT for clinical decision making remains unclear, not for me. That SPECT may, however, have very sound uses. Can that SPECT help determine how to treat a patient with an asymmetric rest tremor who has not responded to high dose of levodopa? This person may be a candidate for DBS, but should one target the thalamus, as would be appropriate for essential tremor, or the subthalamic nucleus, as would be appropriate for PD? That is the answer. As clinicians, we must act responsibly. If a test does not improve patient care and alter what we do for them, then we should not order it. That SPECT imaging quite often leads to changes in PD diagnosis and management of PD patients, increasing also clinicians' confidence in the diagnosis. In some patients with suspected Parkinsonian symptoms or syndromes, that SPECT is useful to assist in the diagnosis and to help guide prognosis and treatment decisions, including avoiding medications but unlikely to provide clinical benefit. Clinicians ordering that SPECT should be aware of its limitations and pitfalls and should order scans when there is diagnostic uncertainty or when the scan will be helpful in clinical decision making. So, concluding, appropriate use of that SPECT includes cases where PD diagnosis is uncertain. We have tremor of uncertain etiology. We have non-motor and or supportive symptoms and features associated with PD, but the classical motor syndrome is absent or is atypical. That SPECT can be a useful tool in the process of diagnosing tremor. A normal result of that SPECT is considered inconsistent with the clinical diagnosis of PD or degenerative Parkinsonism in general, but is typical for conditions such as essential tremor, dystonic tremor, psychogenic Parkinsonism, drug-induced Parkinsonism, and a proportion, not all, cases of vascular Parkinsonism. That SPECT should not be relied on as a substitute for a careful, experienced clinical assessment and follow-up, and in the end, only a clinician can make a diagnosis, but with the valuable support of our friends, our nuclear medicine specialists. Thank you very much.
Thank you very much, Dr. Leonardos. We have a question from the audience. They say, in case of borderline diagnosis, clinical diagnosis of Parkinson's disease, and a DAT scan negative, what are the next steps? I think it's referring to you.
So it's a very interesting question. Personally, I would recommend a very close follow-up, and probably I would try some rasagiline, which is not a truly dopaminergic support from outside, but it helps maintaining the already existing dopamine in brain. So I would recommend some rasagiline, and I would be very, very close following up this patient. And probably when something different appears in my clinical evaluation, I would also think about a second DAT scan, but later on, yeah.
So, I don't know, any question from the audience?
Thank you, all of you, for your excellent presentation. Thank you very much. Dr. Labrakos, I would like to ask, if you think, I am wondering, does motion correction program work properly? I mean, can you overcome the motion of the patient and provide good quality results?
So, as I said in the presentation, some motion can be corrected. The first patient I show you, I have corrected manually every slide by myself to have a perfect align of the slides. And it appeared to be a normal scan. But there are a lot of movement that can be corrected. If you have the possibility, rescan the patient. And I would like to say before we close, a very interesting thing about sweats. Sweats is it's now 50 to 20 years we heard the Swedes. I think in the future, I think with quantification, with better quantification, maybe we will see shifting these sweats, that these normal scans, if quantifications, normal values are very close to borderline, maybe sweats then, when they reported 20 years ago, we didn't have quantification. Maybe those scans was balanced loss scans. That's a question for the future for all the young generation to have in mind, because then we didn't perform quantification. We didn't know the values. Maybe we were seeing pathological scans, but with visual assessment was as normal.
If I may add something here, Swedes are really a very, very, it's a huge debate in our field as well. So I really believe that there is still work to be done here concerning Swedes. There is, let's say, a group of Swedes that it's really dystonic tremors. We should not forget this. Not very common form, but otherwise I would strongly agree with Lucas that a more thorough investigation with quantification will lead us as well to new interpretation of these weights, because so far I was never satisfied when I was attending lectures by well-known specialists about Swedes. It was always something missing. Yeah, 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 exactly. Unless it is a clear dystonic tremor, which is 1 out of 4 cases, I'm not sure about the rest.
So,
I think we're on schedule. Thank you for attending the first session. Thank you, Dr. Labrakos, Dr. Leonardos, and the rest of the panel. So it was a very interesting approach, the ladies, of course. And let's have a 30 minutes break, and we'll come back with a case-based workshop. So stay tuned. A 30 minutes break. Thank you. Ένα.
Από εδώ.
Εντάξει. Εντάξει.
Θα το αφήσουμε
Να το πάρω.
και θα...
Δεν χρειάζεται.
Οκ. Τώρα είναι κλειστό ή ανοιχτό.
Τώρα είναι ανοιχτό.
Ένα.
Οκ.
Εντάξει.
Θα βλέπω και εγώ τη Λίζ.
Okay, so dear doctors, dear colleagues, we're back. This is the second session regarding the case-based workshop. Along with us is Mrs. Liz Clark from UK, so it's a virtual connection. So Liz will give us a presentation concerning the top tips of quantification. So let's connect with Liz and start the second session. Okay, thank you.
Yeah, thank you very much. I hope you can all hear me clearly. Good afternoon. My name is Liz Clark. I am the European Application Specialist for GE Healthcare. And I'm just going to give a short talk today, giving you some top tips on how to have confidence in the quantification you perform with that Speg. This is my disclosure slide. As I said, I work for GE Healthcare. So quantification was added to the SPC of iaflupane I123 injection a couple of years ago now. So it is part of the protocol that you should be using. As an adjunct, visual interpretation may be assisted by semi-quantitative assessment using CE marked software, where iaflupane I123 injection uptake in the striatum is compared with uptake in a reference region and compared against an age-adjusted healthy subjects database. It goes on to say that final assessment should always consider both visual appearance and semi-quantitative results. So you're looking at both. Visual assessment remains a very important part of the report. Quantification is in the guidelines. The European Association of Nuclear Medicine, alongside the Society of Nuclear Medicine in the US, say that in the clinical setting, semi-quantitative analysis can be an adjunct to visual interpretation. And some studies have shown the addition of quantitative information results in improved diagnostic performance. The British Nuclear Medicine Society endorses this, but then goes on to say that quantification is particularly useful in balanced striatal loss cases that can be seen in Lewy body dementia and Parkinson's plus syndromes. So what is semi-quantification? I apologise as if it's repetition of anything you've seen already this morning, but it doesn't hurt to have a refresher. So when we are doing quantification, we're doing semi-quantification, and we're looking at data in one region aligned to a background area, and we produce specific binding ratios in relation to that background. These are the commonly produced regions of interest. There are a number of quantification packages available, but most of them provide the same regions of interest. So you have your whole striata on the right and left, the caudate, the anterior and the posterior putamen. And this is an example from the DATQuant software. And you can see the background region is in the occipital area here. And these regions give us a whole array of results. So this is the table again from DATQuant. And if we just look at this first column here, these are all the regions along the top. So striata, caudate, putamen, etc. And looking at the first column, the first row that we get is the measured SBR for that region. The second row is the mean SBR from the normal database for a patient of the same age. The third is the deviation of your result from this mean, and then the fourth is the Z-score. You can choose to see the putamen to caudate ratio as well, which is the ratio of counts in the putamen to counts in the caudate. We often get asked, what is a Z-score? It's an indication of how different your SBR figure is from the average SBR figure within your normal range. And a Z-score of 2 is the boundary for the 95% confidence interval. So that means that 95% of true normals should sit between +2 and -2 Z-score. In the case of DAT-SPECT imaging, we don't have a condition that has a positive Z-score. So when we're looking at this plot, the further down that this red dot goes, the higher is the probability of abnormality on the scan. So the top tips are really what we would always emphasize anyway for visual assessment. The first one being high quality acquisition. DAT-SPECT imaging has been around now for over 25 years, and there's always been a very big emphasis on the quality of acquisition, how well you acquire that raw data is very important for visual assessment, and it's equally as important for quantification. So you need to get a very tight radius. You need to get those camera heads in as close as you can. You need to get high counts so that your quality of image is very good. Any motion on the scan is going to mean placement of regions is difficult, so you need to make sure the patient lies very still. Processing is, again, equally as important. Consistency of processing, normal database match, and checking your ROIs. Medication and assessing multiple parameters and being flexible with your Z-score. And I'll go into all of these in a little bit more detail. So your patient acquisition, as I said, is crucial. The technologist or radiographer plays a very important part in DAT-SPECT imaging, and you have to get that acquisition right. You're looking for a circular radius of between 11 to 15 centimeters. Now, 15 centimeters is important for quantification because all of the normal databases have been acquired with a maximum radius of 15 centimeters. So in order to match to that normal database, you need to acquire in as close as possible the same way. EANM guidelines recommend a total count for the whole study of greater than 1.5 million to have an optimal scan quality. And as I've said, motion is really, really crucial. The patient needs to lie still. On the right-hand side here, you can see kissing chordates, which is a sign of movement. And motion correction packages that you have with your cameras don't generally work because the patient can move in all 3 different planes, and correcting that is very difficult. So you need to get the scan right from the beginning. Consistency. This is becoming more difficult because we're getting new collimators coming on the scene. We've got the LEHRS collimator with the GE systems. We've got new Siemens collimators. And then in addition to that, we've also got new camera types. We've got these new CZT camera types, which are changing how DAT-SPECT appears and changes the quantification. So when you are processing or looking at your scan, image timings is important. Image timings is the delay time from injection to scan. The delay time for DAT-SPECT is 3 to 6 hours, but try to be consistent and scan between 3 to 4 hours because the background does change as you move to that 6-hour time period, so your quantification number can change. If you've got a patient returning for a follow-up scan, if they've had a scan that was thought to be equivocal and they're scanning again 18 months later, make sure that the patient, when they return, is scanned on the same camera and the same collimator. Because if you want to compare your quantification, you need to make sure that everything you've done is done the same as the previous scan. As I've said already, radius less than 15 centimeters really is crucial. I do accept that these patients can be difficult to scan and sometimes you have to go out a little bit further. But if you can keep it at 15 or below, then your quantification is more accurate. And again, processing. And by processing, I mean your reconstruction parameters. You need to process the data in exactly the same way as it's processed by the quantification program for the normal database. So I would always recommend bringing in the raw data into the quantification program and let the program process it for you. And it will use the standard parameters. You can see from this slide here that if you change your post-filter cutoff, your SBR does change. So you have to be consistent in how you reconstruct your data. And as I said, make sure it always matches how the normal database has been reconstructed in the program that you're using. Background region placement. If you have a quantification program that allows you to change the background, the latest version of DATQuant does allow you to move the background, then do check that background region because sometimes it can be placed too close to the edge of the skull or there might be small infarcts in it. So if you get reduced count in that background, it's going to artificially lift your SBR number. And this is an example that came to me in the UK. I don't know how clearly you can see this, but the background is quite close to the edge of the skull. And although it was a normal scan, a figure of 4.7 and 4.69 is a very high SBR, even for a very normal scan. You normally expect about 2.5. So they sent it to me. They were a little bit concerned about it, and we just moved the background in, moved it onto a more uniform area, and it came down to a number that we would more expect, 2.7 and 2.7. So just, you don't have to change it very often. In 90% of cases, there is no need to do it, but just be aware of that and just check it if your numbers look a bit odd. Patient tilt. If your patient's head is tilted on acquisition, one of the values of quantification is that it will be corrected because the program will take your data and align it to the template and it will correct for any tilt. So normally when I'm processing, certainly on DATQuant, I don't do any reorientation. I allow the program to do it for me. And you can see here on the top set of images, we've got this asymmetry on the slices, which is a result of tilt, and it's been corrected on the bottom by the quantification program. Medication. We're getting more and more information about medication and the effect that it has on DAT-SPECT imaging. This is what it says in the SPC. We've just recently had a new paper, a review paper published that looked at in more detail at the effect of medication, but this was predominantly for visual assessment. One thing to point out that is often noted when we present this in the UK is codeine has been added to this list. So that's just something to be aware of. When you're quantifying, you need to be even more careful with the medication that the patient may be taking. Selective serotonin reuptake inhibitors such as sertraline may increase or decrease IF-loopane binding to the dopamine transporter, and often the referrers don't like to take the patients off this medication. So just be aware that sertraline can change your numbers by around 10%. There is also evidence that venlafaxine may also affect SPRs. And this becomes even more important, as I said before, if you are doing a follow-up scan and you're looking to see if those numbers drop, if there is a bigger indication of disease, then be especially aware of any change in medication between those two sets of scans. Assess multiple parameters. I don't know how clearly you can see this scan, but visually, this looks like an abnormal scan. We've lost the tails here. These are just chordates. But if you look at the striator ratio and you look at it on the plot, it's saying that it's normal, which is very odd. And we often get these sorts of cases sent to us for explanation. And sometimes when you get a scan like this, the chordate upregulates. And the average count per pixel in the striator can be artificially raised, which takes it into the normal range. So you need to look at a number of parameters. Look across at the putamen, and in particular, look at the putamen to chordate ratio, because if you've lost that tail of your comma, then you should have an abnormal putamen to chordate ratio. This particular ratio is independent of age, independent of camera type, and independent of any problem in the background region. So it's a very stable region to look at as well, and a useful one to use. This is an example of a balance loss. So rather than going from a comma to a full stop, we've had this overall reduction of the chordate and the putamen reducing at the same time. And quantification is especially useful in these cases because you need a lot of confidence to call that an abnormal scan visually. But if we look at the numbers, minus 2.6 Z-score, minus 2.5, clearly abnormal, overall reduction of the striata. But in the case of balance loss, the putamen to chordate is normal because the comma has been maintained. And finally, which Z-score cutoff to use? When quantification first started with DAT-SPECT imaging, the cutoff was always assumed to be a Z-score of -2, but it really shouldn't be an absolute cutoff. You need to look at it and look at the scan. And this particular paper from the Morbelli group in Italy looked at less conservative cutoffs for a Z-score for the SBR. And they concluded that the results show that different cutoffs should be considered when reporting DAT-SPECT scans in PD or DRB patients, and perhaps the use of less conservative cutoffs between 1.3 and 1.8 seem to provide an increase in sensitivity. And certainly here in the UK, a lot of our reporters are now using a Z-score of -1.5 as their cutoff rather than -2. So in summary, visual assessment remains the primary form of assessment with quantification as an adjunct. I would say that use quantification in every patient. Don't just use it in a patient that's difficult, because then you get used to seeing the numbers, you get used to learning the problems that might come with quantification. Check for possible medication or technical errors if your numbers don't agree with what you're seeing visually. Check multiple parameters and be flexible with your Z-score interpretation. And that's it. Thank you for listening.
Thank you. Thank you. Hello.
Hello.
Hello. Thank you. Thank you, Liz. Thank you for this excellent presentation. And now we will pass Dr. Labrakos to start the cases. And please remain connected for comments concerning the case presentation and discussion. Okay, we have a question from the audience. Yes, please.
Yeah.
Το μικρόφωνο. Give me. Okay, here is.
Congratulations. Thank you for your presentation. I would like to ask you, sorry.
I can't hear a question.
Hello.
Hello.
Hello. Thank you so much for your presentation. It was really excellent. I would like to ask you, which is the cutoff which recommend for us to make clear actually for the background, which is the cutoff for the background in order to see if it is high activity or is less activity or is the appropriate activity for the background. Is there any cutoff?
How to assess it?
Apart from the ratio, apart from the SPR, just only for the background.
How? I'm not sure of the question. How do you check the background, or should you check it on every patient? Is that what you're asking?
Yes, and which is the appropriate cutoff in order to say that we have, the appropriate, uptake, or we have
appropriate.
Less or more.
Yeah. That's a difficult question. In 90 to 95% of cases, you don't need to do anything with the background. It's normally put in the right place. But if you look at your numbers and they're looking higher than you would expect to see with that image, then check your background. And you do have the ability just to move it in a little bit. And there has been some work done that says that it doesn't significantly alter, but it will just make it more accurate. There isn't really a cutoff as such. It's just visually assessing where that background sits and is it sitting over an area where there's no uptake. Does that make sense?
Okay. Yeah.
Okay.
All right. Thank you very much, Liz, for your nice presentation. So
The first case.
Now we'll start with the cases. But before we start, I would like to explain how we're going to do that. First, we're going to see reconstructed image from patient. And I want you to answer which you will be given 4 answers, and I want you to choose the correct one for every patient just with the visual assessment. So we're going to show you a reconstructed image. You will answer what's your opinion, what is correct for the patient. And then all together we proceed to quantification via DATQuant, and then we will repeat the same answers and we will see what changes in answers we'll have. I must say that all the cases are selected just for quantification purposes. What does that mean? We're not interested now about the clinical history of the patient or what produces what. We just want to show you how quantification change your final interpretation. All right? That's the important in this class today.
And Lucas, please remind to the audience that they have to connect using this QR code in the screen. So please connect to the Slido to see the questions.
We'll have to from our mobile.
Exactly, from your mobile or from
all right,
the laptop.
so we're gonna wait for 2 minutes for everyone to download the
to connect with the Slido.
Yeah, to application, to Slido.
Excellent, excellent.
Okay.
We have positive results. Let's start. Let's start.
Να το αλλάξω? Ναι, το κατέβασαν όλοι νομίζω.
Okay.
Everybody downloaded?
Yes.
And we will... okay, one more time.
One more time, the QR
code. Okay, let's connect with your mobiles. And during the presentations, this QR code will also appear for those who will connect later. Okay, let's start.
Okay. So we will start. Okay, we're waiting a little.
Okay, ready? Ready.
All right, so we're going to start with the first case. We're going to show you this is the image from our first patient. And now I want you to answer one of the 4 questions for that patient. Okay. We're waiting.
Okay.
All right. So I'm leaving this question for, let's say, 1-2 minutes with a delay, 1 minute.
Less than 1 minute.
Less than 1 minute to answer everyone. Okay.
Okay. 30 seconds more. 30 seconds more. So please vote. Use.
Interesting.
Το QR code είναι στη γωνία. Εκείνο που είναι στη γωνία. Όχι, αυτό είναι που θα...
Ναι, το ίδιο πράγμα.
Okay.
All right.
So
So we're done with the first voting, and now we'll start with quantification of this particular patient. So I want all here in this room to open patient number 9 in your PC. Patient number 9.
είναι από τα γένια.
So the first panel will be motion correction. Let's skip this part and we'll keep the original data.
Το 9.
All right, and now we entering in the page that we need to align the axis. So everybody align the axis. All right. All right. If you all align the axis, if you have aligned the axis, let me check everyone. You proceed.
Τα προηγούμενα.
Ωραία, original τα αφήνεις. Και εδώ κάνε align the axis. Φτιάξε τους άξονες. Νομίζω ότι είσαι καλά εκεί. Okay. Let me check all the attendance. All right. All right. You have aligned the axis. It's better to see them clearly. Let's try to see them clearly. See? Δεν ξέρω γιατί έγινε αυτό. Ναι, έγινε μικρό, αλλά δεν ξέρω γιατί έχει πειραχτεί. Ναι. Έγινε μικρό τώρα. Όχι. Δεν ξέρω γιατί έγινε αυτό. Δεν πειράζει, τον έχεις ευθυγραμμίσει. Πολύ καλά. If you are aligned, you proceed to past. Ωραία, very nice alignment. Ωραία, κάναμε. Ωραία, εντάξει.
Το άλλο το πρόγραμμα το κάνει καλύτερα.
Original. Ναι, σε βγάλει κατευθείαν, ναι.
Τώρα είναι επειδή είναι σε λάπτοπ, δεν είναι σταθερό.
Alright.
Τι?
We're all done. Nice alignment. It's okay. So when you finish the alignment, then proceed to past. Click the past button. All right. Complete the collimator name, dose, and radiopharmaceutical. All right.
Πρέπει να πατήσετε past. Μέχρι να κάνει θέλει λίγο.
Okay, if everybody completed the Q-check, you press OK.
Ναι, δεν έχει
Πάτα μου το βλέπουν οι άλλοι. Okay. So, does everyone have results? Okay. So what can we see from our results after quantification? I want you to check the advance check button down at the to see all the parameters, anterior, posterior, putamen. And now you're going to see all the values. So now that we have all the values, I will send the same question again. Did everyone saw the values? Because now we're going to ask again. All right? Okay. So we start. We have some information from the patient's MRI, but again, we will give you the same set of questions. All right. Let's see now. Start voting. We have a delay from our audience via internet, so we're going to wait. Πώς είναι. Στη δεύτερη. Και μετά θα εμφανίσει τα συγκριτικά. Εδώ ψηφίσατε εσείς. Όχι, αφού λέει μόνο 3. Γιατί δεν έχετε ψηφίσει. Δεν τους έχει βγει. Ξανά πρέπει να το κατεβάσουν το QR code. Όχι, ενώ δεν τους εμφανίζουν. Είναι μόνο 3 εδώ λέει. Άρα δεν φαίνεται πουθενά.
Όχι, έχει φορτώσει τώρα.
Α.
Εγώ ψήφισα.
Ωραία.
Τα έκανα send εγώ.
Το έκανες send. Okay, we're gonna wait for all the participants to vote.
10 seconds.
11 άτομα είναι μόνο. Ούτε εδώ δεν έχουν ψηφίσει.
Τίποτα. Λουκά,
εδώ ψηφίσαμε όλοι, εδώ μέσα. Εδώ είναι μόνο 14 δείχνει. Εδώ είμαστε μόνο 20 και. Έχει γίνει κάποιο θέμα? All right. Okay. So, let's have the results from the second. Okay, now let's compare the first answer and the second. That was the first answer. 86% voted that it was a pathological on right putamen. And now, after quantification, we have 38% of the audience vote for pathological on right putamen and caudate, and 24% pathological on right putamen, and normal 90%, and pathological on both striata 19%. Now, if we return in quantification, okay, if we see again the quantification, we see that all the values are abnormal. All the values. of course, we can see that left striatum, it seems in the range of normal values, but it's way down the normal, 36%, in the limit of 2 z-score. This is, for me, this is also a pathological scan in both right and left striatum. So immediately we can see that our first visual impression was wrong. After quantification, the correct pathology appears. Okay, let's pass now to the second case. Open, please, the patient with the name 3. Open patient 3. Okay, before doing that, we're gonna show you again the reconstructed image, and you will start voting for the second case. Now, this is the second case. Looks similar, but let's see. Please vote with your QR code on Slido. What's the correct, by your opinion, answer?
Okay, please
Okay.
vote. We have some seconds.
Left, yes, for
20
voting.
seconds, 20 seconds left. Please vote. So, Lucas.
Okay, we're
that's it.
done voting. Now let's proceed to quantification. We see 90%. They think that there is a pathological scan on right putamen and caudate. So we proceed in quantification. Ms. Ganu, please proceed. Thank you very much. So we skip the motion. Θα δω τους άλλους. Τους άλλους. Στριφτολή. Όχι, καλά είσαι. You're good. Καλά είσαι. All right. Put this axle first. Okay.
Εγώ πιστεύω ότι πρέπει να αλλάζουμε και το background. Γιατί μετά μπορούμε να πατήσουμε edit drawings και να αλλάξουμε που τα έχει πάρει. Και σε κάποια περιστατικά χρειάζεται να το κάνεις αυτό. Τώρα δεν το κάνουμε βέβαια.
Είναι δύσκολα όλα πολύ.
Τι θέλετε, εύκολα? Άμα ήταν εύκολα να πάτε αλλού να εκπαιδευτείτε. Εδώ τα πολύ δύσκολα. Αυτά για να τα βρεις μου πήρε 1 μήνα. Ναι. 5 βάλε. 5. Ναι, βάλε 5 μιλικιουρί και δείχνεις OK. So you're done here? All right. Okay. So we can proceed now. Okay, as you can see, we start processing the data after alignment. And let's wait for the results. I'm very curious what gonna see now. What are we gonna see? Περίμενε. Εντάξει, δεν το κάνω εγώ. Να. Ο Θάνος φταίει. Okay, Thanos said we have time. We're waiting for that one, Thanos. Sorry about that. It's a little bit late. Okay. We passed. We complete the parameters. Normally, those parameters are entered automatically. I don't know, this is because it's a demo version. Maybe you need to put them yourself. So we have our results. Put it in advanced setting to check all the levels of striatum. Look them closely. And when you're feeling confidence about your results, we can proceed to voting again. Liz, if you can hear me, do you have any, let's say, comment on this case?
Yeah, I'm just checking I'm looking at the right one. Patient 3, age 80.
Yes, wait, because sorry, those scans I have sent you were with the correct order. When they put them here, they changed the order. So for you, Liz, it's case. If you put them correctly as I sent it to you, it's case 2. So you will keep. So we'll keep patient 1, 2, 3 as in order I sent it to you. Okay.
Okay. Yeah. So I was looking at patient 3. When I looked at patient, do you want me to tell you what I think or not?
In this case, yes, please.
Yeah. When I looked at it previously, I'd got balance loss.
In the first one you saw?
No. In this one that you're looking at now.
Yeah.
I had balance loss.
No. It's not the correct one.
Okay. I think my order is wrong. Yeah.
Yeah. So for you, the third case, you will open the third one I sent you. You will keep the order as I sent it to you. 1, 2, 3. Okay, because here it's a totally different order. Okay. So in the next patient for you, I'm saying that you will open the patient number 3.
Oh, I've got that. I've processed that. Do you want me to share my screen?
No, wait for everybody to process patient 3. Okay, we remain at patient at case 2. At case 2. Now that's the case 2. All right. Now vote again. We have 1 minute to vote. Start voting. This is the MRI findings on this patient. Liz, till the voting endings, we can share our PC to you, so you don't have to open your cases. You will see.
Yeah, that would be much easier.
Okay. So don't worry, we will share our main laptop to you, and you will see our cases as it should be. Okay.
That's better. I can see it.
And we'll discuss next case with you. Okay.
Okay.
All right.
Yeah, I can see it now.
30 seconds we have. Μετά θα δείξει, μετά όταν θα τελειώσουμε θα δείξει και τα δύο. Ό,τι έκανες και πριν. Ναι. Αλλά δεν τα έχεις όμως και τα δύο να φαίνονται δίπλα-δίπλα. Δεν μπορούμε. Pass back forward. Okay, we have 10 seconds more. Please vote. No. This is an MRI, and it shows clearly what's the problem. So, all right, we're done with voting. Let's see the results. Now, we have 71% thinks that this is a pathological on right putamen encodate, and 29% thinks that it's pathological or only on right putamen. But if we let's check the first voting. All right, we are confident. I think that after quantification, a lot of people change to bad answer. It's okay. It happens. All right, let's pass to the third case. For here, for the audience here, open patient 2. Patient 2. Patient 2. Ναι, είναι και χαγιά. Είναι και χαγιά.
Δεν θα τους πούμε τις σωστές απαντήσεις.
Τους είπαμε, ήταν αυτοί, τώρα ήταν πέσανε τέτοιο, ήταν λάθος.
Ναι.
Yes. So before we start, let's see the question and the reconstructed image. All right, that's the reconstructed image. Please see it fairly, and when you are ready, hit the question. All right. The question is already open. The answers, they are already open. Please vote. What do you think is the correct answer in this case? Ναι.
Δεν θα τους πούμε.
Τώρα θα σου πω.
Ποια ήταν από αυτές που είπαν οι σωστοί.
Εδώ το βρήκαν ουσιαστικά οι περισσότεροι.
Ναι, αλλά δεν είπαμε ότι είναι αυτό το
Εντάξει, θα το πούμε τώρα εδώ στο...
Επίσης, μήπως να δείξουμε και πώς μπορείς να κάνεις edit rows, να αλλάξεις λίγο
ναι,
το...
θα το κάνουμε γιατί στα τελευταία περιστατικά πρέπει να ανταλλάξει γιατί έχει ατροφία. Οπότε θα το βάλουμε λίγο πιο πάνω. Στο τελευταίο περιστατικό.
Please vote.
Okay, please vote.
We have 30 seconds more.
30 seconds. Wow, this is an easy one. Come on, guys. This is an easy one. This is a...
10 seconds more.
10 seconds. Liz, I think that was your case, huh?
What?
Okay, let's see the results from this first visual. Very good, guys. 59% thinks that's a normal. Only 27% think is pathological on right putamen, and 40% of that is pathological on both striata. All right, let's proceed to quantification.
We'll see.
Αφού γίνει η ποστικοποίηση θα αποστείλεις. Ναι. Follow the steps, correct alignment, don't forget it, it's very important. Check all the images on the slices from the top to the bottom. And in this case, besides Liz, I will let our dear friend Leonardo's to make a comment because it's from his patient, this case. After we finished quantification and voting, we don't want you to all right. Passed. Okay. And waiting for the processing data. All right. Very nice. Check the image, check the... For the audience here in the room, check all the values if you have them. Because you are you're about to answer. All right, check all the values. All right. All right, now that we have the values, we're waiting a little bit, Liz. And all right, we have the values now. Liz, do you want to make a comment on this case?
Yeah, I think this is a balanced loss case. I think that I can't see the putamen to caudate ratio, but all of them are down. The background is very high. Visually, the background is very high, which is an indication of balanced loss. And it's down abnormal anyway. It's abnormal on both sides, but balanced.
Correct. I will give the speak to Mr. Leonardos to make a comment.
No. Okay, this patient came with a very complex clinical picture. She was very unsteady. She had some falls. She has undergone a surgical procedure for cervical myelopathy as well. And he was referred to me as a possible normal pressure hydrocephalus. So after my clinical examination, we had loss of postural reflexes. She was very bradykinetic. She had stiffness, but not in the way that an idiopathic Parkinsonian patient exhibits stiffness. Her stiffness were located predominantly not in the periphery, but more axial. So after having the DAT scan results, she was diagnosed with a Parkinson plus syndrome. We tried to give her some levodopa, but until the dosage of 400 milligrams per day, she did not have any substantial clinical benefit. And then she never came back for follow-up. As it's very common in cases with Parkinson plus syndromes, he changed a physician as well.
Thank you, Mr. Leonardo. So, correct, everyone. Let's try again the question to see if all the participants understood what happened here. We see also the results from MRI. And let's vote again. I'm very curious to see what the results will be this time. All right, please vote. 30 seconds remaining. Okay.
10 seconds.
we experience a small delay of 20 seconds with our audience on internet. Okay, we're done. Let's see the final results for this case. All right, that's better. Pathological on both striatum, 68%. All right, we're getting somewhere. We're getting somewhere. All right. So we saw that in this case, the differences was a norm in responses. First, the majority thought it was a normal, and now the majority thinks it's a pathological, which is the correct answer. Okay, this is a typically balanced loss case. All right, let's pass to the next case. We will show you the image. All right. All right, this is the next case for the audience here is patient 6. Open. Αυτό είπαμε ότι είναι balance loss, εντάξει.
Δεν ξέρουμε τι είναι balance loss όμως.
Ξέρουν τι είναι balance loss. Okay, next patient 6 for the audience here. Open the patient 6 and you can start voting for this patient. All right. Oh, again, a tricky one. Who find those cases? I don't know. All right, please vote. Just with the visual assessment. All right, 20 seconds for voting. Please, everybody vote to start quantification. All right, 10 seconds. Almost done with this voting. All right, let's see our results for this case. All right, 43% thinks that this is a normal, 29 that it's pathological on both striata. 90% thinks it's pathological on both putamen, and 10% that is pathological only on the right putamen. Okay, now let's start quantification. Ms. Yanou, if you please can proceed to quantification. Thank you very much.
Οπα.
Right. Mm-hmm. We're waiting from the results from quantification. The system is a little bit.
Ίσως πριν προχωράμε στο επόμενο, να εξηγούμε το προηγούμενο γιατί είναι έτσι, για να μπορούμε μετά το επόμενο να το πούμε σωστά. Progress.
Το ξέρω. Okay. We're past? Past, yes, yes. All right, complete the... Liz, I'm waiting for your comment, Liz.
I think it's like previous one. I think it's another balance loss.
All right. So should we throw the question or to explain the balance, why it's a balance loss case, meaning in quantification to everybody to see that this patient has high background ratio, background uptake, and also if you can see the large images here. As I said in my presentation, what should we check also beside the size, shape, intensity? We need to see the lines, the color lines. They're not must be interrupted. Here, they're not quite smooth. That's an indication that something is wrong, all right? And also that the increased intensity of background present almost everywhere in the brain, all right? So check those things, those four things I said in the presentation about shape, size, color, and background. All right. So let's start again the voting in this case. Τι σκέφτεσαι να σου. Τι σκέφτεσαι, τι μπορεί να ήταν αυτό, All right, 30 seconds. Please vote. As I said in the beginning, the purpose of this training is not to see what the patient has. It's to establish that quantification alters our final interpretation. That's the main goal here. All right. Okay, let's see our final results. Perfect. 77% now thinks has the correct answer. Of course, it's a balance loss case, clearly, no doubt on that. All right, let's proceed immediately to the next case. Let's, so, all right, this is, all right. This is also a very interesting case. We will see. Please vote in this patient. Check in visual interpretation, as I said, those four clues: size, intensity, shape. Check the background, check all the brain. before answering. Αυτό είναι τέλειο περιστατικό. Και θα δεις πώς τώρα. Πολύ ωραίο περιστατικό αυτό. Εδώ τώρα θα μολαθούν. Εδώ θα ξεχάσουν και αυτό που ξέρουν. Αυτό είναι, ναι. Αυτό είναι περιστατικό που είναι... Όλα δικά μου, δεν έχει κανένα. Όλα. Okay, 20 seconds, please vote.
Το 8.
Πριν το ανοίξετε και το δείτε στο... Γι' αυτό δεν σας το λέω. Ακόμα το... Ποιος αριθμός είναι. Please, first vote. All right, all right. Let's see the results from the first voting. 75% think is pathological on left putamen. Very good. 57, yes, 57, sorry. 57% thinks that this scan is pathological on left putamen. All right, let's start the quantification. This quantification is patient number 8. Ήξερες γιατί το έκανες.
Εδώ θα πειράξουμε τα ροϊς.
Όχι, δεν θα πειράξετε.
Μάλιστα.
Περιστατικό. Θα δεις γιατί.
Δεν μ' αρέσει. Λίγο δεξιά. Δεν θέλω να το στρίψω. Θέλω να φαίνεται.
Κάνε πάση.
Τους άξονες έτσι ώστε να φαίνονται και τα δύο ραβδοτά στις ίδιες τομές. Μην φαίνεται αρχικά ο ένας πυρήνας και μετά εμφανίζεται
αν τα βλέπει
ο
και
άλλος.
εκεί. Κοίταξε να δεις, στο το balance loss δεν θα δεις ποτέ απόλυτα συμμετρικά. Θα δεις κάποιο θα είναι λίγο περισσότερο, λίγο λιγότερο. Ναι. Δεν είναι Parkinson αυτό. Αυτό είναι για plus, ναι. Κοίταξε, όχι, δεν είναι λάθος γιατί. Γιατί αυτό το περιστατικό παραδείγματος μπορεί να μην ήταν ούτε plus. Αυτό μπορεί να ήταν μικροαγκιοπάθεια. Γι' αυτό και δεν μπορείς να το πεις. Το άλλο το σχολιάσαμε ότι ήταν plus γιατί έχουμε το ιστορικό από τον Λεωνάρντο. Άρα προσέξτε γιατί μπορεί να δεις balance που να μην είναι plus και να είναι δευτεροπαθής. Αυτό που είπανε, πρόσεξε, να ξέρεις ότι στην τελευταία έκδοση, εγώ για μένα, άμα θες τη δική μου άποψη, κάτω από 1. Ό,τι δεις πάνω από 1 είναι παθολογικό. Εγώ έχω δει περιστατικά που είναι και με κάτω από 1 και είναι παθολογικά. Τόσο μικρό στρίκ. Ναι, γιατί συνδυάζεται μετά και με την κλινική εικόνα. Καταλαβες. Αυτό το 2 είναι λάθος. Και θα τα αλλάξουν και αυτοί τώρα. Το έμαθα δηλαδή ότι θα τα αλλάξουν, θα το κάνουν 1. Okay, we have the results. So, Liz, I need your opinion on this.
This is a tricky one. I don't know if there's some vascular involvement. There's a lot of reduced uptake in that background. But the uptake in the striatus, I can't see the putamen to caudate ratio. Can you possibly put that on the table for me? The ratios. If you go to the table at the bottom and just click ratios, yeah, that'll do.
What do you want? No,
Oh yeah, yeah.
This one?
This is this is a difficult one. I think this
Okay.
is case 10 that you sent me, isn't it?
So let's discuss this case because indeed it's interesting. We see that the majority of the values are in normal area, +8, +13, +8, in deviation meaning. And we have the posterior putamen, left posterior putamen decrease, all right? But I'm not going to say yet the but, what I mean. I want you to figure out where is the but. We're going to solve the question again. You're going to answer it, and then we discuss this case. Okay, let's hit the second, the question again. All right. All right, please vote in this case.
Πούμε στο τέλος, να εξηγήσει λίγο και στο κοινό αν πρέπει να κοιτάει το deviation ή το z-score.
Το ίδιο πράγμα είναι.
Το ίδιο πράγμα είναι.
Ναι. Το deviation, το z-score είναι οι τιμές ουσιαστικά που θέτει αυτή σαν φυσιολογικές και το deviation είναι το ίδιο πράγμα, απλά το δίνει σε ποσοστό.
Οκ, θα μπορούσε να το εξηγήσει λίγο για να το καταλάβουν, γιατί τώρα δεν ξέρουν τι να κοιτάνε και δεν ξέρουν σε ποια ποσοστά είναι παθολογικό. Αυτό.
All right. You're right. All right. Please vote, and then we'll discuss this case further.
Γιατί κάνουν την ποσοτικοποίηση και μετά πάλι το πατάνε λάθος. Άρα δεν ξέρουν σε ποιες τιμές θεωρείται παθολογικό ή φυσιολογικό.
10 more seconds, Lucas.
Τι?
Okay.
Let's give 20 more seconds.
20 more seconds, please. Vote. Vote,
please.
Don't hesitate. It's a very easy case, this one. Why you... I don't know. Yeah, why do you hesitate? I don't know. This is a very easy case.
And anonymous.
Hmm?
And it's also anonymous.
Yeah,
so...
it's also anonymous. Yes. All right, let's show the results. Okay, now, similar to the first results, let's see the first results to remember. All right, so the final, it's almost the same. Now, let's return to quantification. All right. I said before but. I said already that posterior putamen, left putamen is low, 0.92 or minus 25%. I must say that deviation as a score showing exactly the same. Okay, I usually prefer to see the deviation score myself. It's okay. For everyone is depending. But what should have observed is that left caudate is way too high than all the others. And anterior putamen, left anterior putamen is also increased than the others. And if we return to the question, the second question, I put an arrow there, but I don't know, nobody saw it. We see clearly, first of all, clearly we see an enlargement of lateral verticals, correct? All right. But if we can check closely, we can see that this hydrocephalus is pushing the posterior left putamen and it's in different shape than in right. So my opinion, and I wrote it in my report, that this is a totally normal scan. Those changes in the values indicated that something is not corrected structure, not because not only we have low intensity in the posterior putamen, but we have the increased uptake in the anterior putamen and in left caudate. So together those things, and with the findings of MRI, which I saw it afterwards, the truth is, it gives me the confidence to say that this is clearly a normal scan. Because if I put in my diagnosis that this is a pathological scan, and in fact pathological starting degeneration in the left putamen, that for clinicians is immediately a PD, and that would be terrible wrong.
Exactly. It's not my patient. I don't know the case. But for this interpretation, this patient needs immediately a VP shunt. It's not neurodegeneration. It's not. We cannot afford wasting time.
Correct.
With L-DOPA.
Liz, what do you think about now? Any comment?
No, I agree. I when I looked at this before, we finally concluded it was normal. I didn't have all that technical information from the MR, but I could see that the background was wrong. There's something vascular going on or something strange there, but it's a very difficult case.
All right. I'm glad we agree that was a very easy case. All right, let's continue to the next case, case number 6, and this is the image for case number 6. Please vote. A very easy case also. Please vote. We have 30 seconds, almost 1 minute to vote.
Δεν είναι όχι το 6. Το 4.
All right, please vote. 30 seconds we have. Please vote. It's an easy one, this one. Don't hesitate. When we finish this case, Dr. Leonardos will make a comment because it's his patient. Okay. Ναι, εδώ πέρα, ρε φίλε, γιατί το περάσανε. It's okay, it's okay. Θα το πούμε κατευθείαν. Δεν πειράζει. All right, let's see the results. Let's see the results.
Είναι παγίδα αυτό.
Maybe it's a trap, this one. Okay. This case shows that this is pathological on right caudate. Obviously, let's now proceed to quantification and then we'll discuss this case.
F4. Number 4.
Patient, yeah. This patient number 4. Εδώ είναι μαλακή. Γιατί έβαλα εγώ τέτοια ερώτηση. Μπορούμε να βάλουμε μια άλλη ερώτηση που να έχει τα δύο. Να το ρωτήσω.
Τώρα.
Ναι. Να σου πω. Βάλεις άλλη ερώτηση. Ωραία.
Ναι, το 4 είναι σίγουρα.
Εδώ κάνω το pathological on both striatum. Ωραία. Μετά το κάνουμε. Ωραία. Φτιάξουμε την ερώτηση, εντάξει. Technical issues, guys. Don't worry.
Θέλω να φαίνεται λίγο εδώ.
Ακόμα κάνει. Right.
Παγίδα. Παγίδα, ήταν παγίδα αυτό.
Περίμενε αυτό τι είχε κάνει ρε φίλε. Όπα, sorry. Let's see the results. Περίμενε, μην τα ρίξει ακόμα. Let's see the values. Περίμενε να το δω αυτό. Καλά το είχα βάλει αυτό. Καλά το είχα βάλει. All right. Liz.
Yeah.
Your opinion.
I think it's probably normal, but there is reduced uptake in the right caudate. But what is the significance of that? I'm not sure. I think I would probably come down normal.
All right. So before we γιατί έχω βάλει άλλο αυτό νερό. Έχω βάλει άλλο. Μπορεί να έχω βάλει άλλο. Πρέπει να έχω βάλει άλλο να στείλει εκεί. Οπότε άστο, δεν θα είναι δικό σου. All right. That wasn't the case of Dr. Leonardo. So, let's start voting again. Περίμενε. Αλλάξε εδώ και βάλουμε την προηγούμενη όπως την είχα τότε. Ναι. Ναι. Ναι, ωραία. All right. Let's vote again now. Όχι. Εγώ. Ναι.
Άρα έχουμε κάνει άλλη ποσοτικοποίηση.
Όχι. Αυτό απλά δεν είναι του κύριου Λεωνάρδου.
Ναι,
δεν είναι αυτό.
Το περιστατικό αυτό που
είχα βάλει άλλο.
Εντάξει.
All right, let's continue voting. We have time, don't worry, guys. Γεννήθηκε πρέπει να βάλω παραπάνω περιστατικά τελικά, ρε φίλε. Έβαλα 10. Δεν θα μας θα τελειώσουμε πριν το χρόνο. Θα κάνουμε discussion.
Ναι, και τώρα και το deviations.
Μα εσύ που φαγώθηκες, δεν θα βγουν, δεν θα...
Περνάει το ένα. Το Z-score να περνάει το ένα. Το περνάει το ένα. Α, ναι, αλλά... Ναι, αλλά αυτά είναι άλλα νούμερα. Είναι του άλλου προγράμματος αυτά τα νούμερα. Δεν είναι του DATQuant. Εδώ πέρα θεωρητικά όποια
30 seconds.
βγαίνει πάνω από 10% θεωρείται περίπου. Θεωρείται παθολογική. Γι' αυτό εγώ λέω ότι γιατί το είπε. Περίπου 10. Δεν είναι στάνταρ όπως είναι στο άλλο το πρόγραμμα που λέει πάνω από 2,5 φυσιολογικό και πάνω από 2,1. Εδώ δεν υπάρχουν στάνταρ τιμές. Γιατί το είπε φυσιολογικό αυτό, η Λίζ. Αυτό είναι 3%. Το είπε φυσιολογικό. Και αυτό είναι 21%. Εντάξει, δεν είναι το posterior ποιο θα είναι.
Okay. All right, let's see our results now. All right, 86% thinks it's normal. Maybe Liz, they were influenced by your opinion, I think.
Sorry.
It's okay, it's okay, it's okay, it's okay, it's okay. So, this case is also tricky, that's true. If we return to the quantification, all right, what I put here to see is the asymmetry of codate. It's okay in the limit, but for me it's a pathological one, asymmetry, this one. So in this case, I think I personally would give a pathological scan on right codate, probably due to vascular secondary vascular Parkinsonism. All right, so yeah, the ratio is low, and the asymmetry is also increased. So check all the values before your final interpretation, and you will see the small differences that may significant pathological pattern. And when you see, especially when you see low intense uptake in codate, always think of vascular Parkinsonism. All right, Liz, do you agree with me?
Yeah, just a comment there. I think it shows how important it is to look at the structural imaging as well alongside the scan. You need to look at the MR or CT.
Correct, especially for secondary vascular Parkinsonism.
Yeah.
All right, so let's continue. And Dr. Leonardos wants to make a comment.
In both cases, even if this is considered normal, or if it is considered as VAP, vascular Parkinsonism,
it's the same.
We are still not dealing with neurodegeneration. Okay, so that's the point for me. So Madopar here is again useless. So even if we vote normal or a slight deviated problem in the putamen,
for me, the interpretation clinically is still the same, okay?
All right, perfect. Now, let's move on to the next case. We'll show you again the reconstructed image. Hey, don't tell me, guys, this is an easy one, okay? Let's vote. Let's vote. Τι τους κάνω στα παιδιά. Τώρα ξεκινάμε. Just to remind that the QR code is for Slido. Please connect with Slido if someone haven't connected yet. Just to remind it. Εσύ κάνε το για να είσαι. Αυτή είναι η πρέκα. Αυτή είναι η πρέκα. Αν θυμάμαι καλά. Αυτή είναι η πρέκα, ναι. Για να δω. Αχ, Θεέ μου. Σου πω, έχεις το δικό μου. Α, ναι. Ναι, αυτή είναι η πρέκα. Ναι. Okay. All right, guys. Please vote. We have 30 seconds left. We're gonna hit 100% correct answer in this case. That's for sure. Σε θεός. All right, 30 seconds. All right, let's see the results. All right, 81% thinks, what do they think? Pathological on right striata and left putamen. All right, very interesting. Let's start quantification. It's patient. Για να το πεις. Το είδαν όλα. 5. Patient number 5. Το πέθανες. Μπερδεύτηκα. Και εδώ έκανα. Αλλά έπρεπε να το βάλουμε εδώ για να μην φαίνεται. Γιατί με το που το γυρίσαμε φάνηκε αμέσως. Αυτή φταίνει. Δεν συμφωνεί, πάλι έχω βάλει λάθος, ναι. Φίλε, όταν τους έστειλα τις τέτοιες μετά πάλι μου κάναν, δεν ξέρω τι μου κάνουν. Δεν είναι αυτό, όχι, την πάνω δεν είναι αυτό. Το επόμενο πρέπει να είναι αυτό. Δεν είναι ούτε αυτό. Δεν είναι αυτό, αυτό είναι παθολογικό φουλ. Αυτό είναι άλλη ημερομηνία, όχι. Κράτα.
Δεν είναι αυτή.
Η πρέγα δεν είναι, πρέπει να είναι η άλλη.
Η Παπακόν.
Δεν θυμάμαι. Ή αυτή δεν τα θυμάμαι. Έτσι όπως αλλάξανε όλα τα. Μου αλλάξανε τα slide, μου τα κάνανε όλα. Και γι' αυτό εδώ, αυτό. Βάλε μου την ερώτηση σε αυτό. Την επόμενη. Θα μου βάλεις on both striata, on both. How are we with quantification? Still working on it, still working on it, still working on it, still working on it, still working on it. All right.
Λαμπράκο.
Μπερδέψανε για όταν μου αλλάξανε τις τέτοιες μου μπερδέψανε.
Dr. Lucas. Dr. Lucas, we have someone in the audience here that needs to learn.
All right, let's see the results. And I want, Liz, if you want to make a comment here, I will appreciate that.
I think it's just a very abnormal scan on both sides. Technically, it looks fine. Counts are high. The only other query may be medication, but I think it's just an abnormal scan.
All right. Very important thing here I want you to see is that the values in asymmetry may look different. That's because it's almost total total pathological scan. You cannot see this value, and the asymmetry is going to be abnormal for sure, and all the values are high abnormal. So I don't think we have a lot of things to do in this scan. Just to vote again. Let's see the question a little bit changed this time. All right. All right. We'll give you 2 minutes to vote. No. Dr. Nacho said 1 minute. I must follow the program. Ελπίζω να έχω βάλει τον γκέλια μετά.
Τώρα αυτό ήταν το 5, έτσι, ναι.
Κλείστο αυτό.
Και εγώ ελπίζω να είναι ο τέτοιος.
Όχι, τώρα πάμε στο 8 μετά.
Που είναι το 1.
Το 1.
Ναι, αλλά αυτό μήπως είναι κάποιο από αυτά που δεν είδαμε.
Όχι. Μην το βάλεις.
Ναι, δεν το βάλεις. Μην αγχώνεται. Δεν έχω καταλάβει οι τιμές. Ούτε το κοινό έχει καταλάβει σε ποιες τιμές το deviation και το z-score.
Okay. 20 seconds, please. 20 seconds, please. Vote. It's an easy vote. This. Ah, perfect. Yes. Let's see.
Πήγε ένα τραγούδι τώρα.
Please vote. It's a very interesting case.
Όλα interesting cases.
Okay. Okay, let's see the results here. I think you got it right. All right. Pathological on both striata. Correct. All right. Let's pass immediately. We have only a few minutes left. Let's see 3 more cases. Let's go to case number 8?
No, case number 1.
No. Case number 8. Case number 8. Το ένα είναι, θα ανοίξει εδώ, το ένα. Αλλά το case είναι το 8 που δείχνουμε.
Και μετά όμως θα επιλέξουν για το
quantification. Ναι. Μας πρόδωσες τώρα, χαρά. Okay, let's vote. Don't open any patient here, the guys in the room here. Someone said a small secret. Okay, never mind. All right, let's vote in this case. Με πρόδωσες. Liz, do you want to comment on this visual assessment?
Yeah, I think obviously the right side is affected, the caudate and the putamen, I think. The left side looks normal, but until I see the numbers,
Right.
I'm not sure, because that if it's Parkinson's, it's unusual for one side to be affected and not the other. So I'd like to see the numbers to check on that left-hand side.
I liked your comment on Parkinson's disease on this case. It's true. It's true. Normally, and if Dr. Leonardo wants to add something, normally, yes. Okay, so normally in Parkinson's disease, if you see increase degeneration in one part, in most cases you will see also starting in the opposite side, just starting from the posterior putamen. So this case, just from visual assessment, it seems that something else is happening here. We will see the quantification and then we will discuss again. Okay, let's see the results on this case. Pathological on right striata, 78%, very good percent. All right, let's proceed to quantification. All here, open patient 1 in the room. All the patient here. All right. Correct.
Να πειράξουμε και από κανένα τα ροζ και το background, να δούμε πώς αλλάζει. Γιατί μπορούμε να το κάνουμε. Αλλά
Ποιο?
μπορεί από
Δεξιά
παθολογικό να το πάλι
είναι
φυσιολογικό.
παθολογικό.
Γιατί όσο το πάνω έχει περισσότερες
Σου λένε οι τιμές,
στο
τσεκάρε
background.
τις τιμές να δεις.
Δηλαδή, άμα εδώ πατήσουμε edit
Τι πιστεύετε,
rows
παιδιά? What do you think?
και πάω, περίμενε.
Το αριστερό. Μπράβο,
Αντί
για
για
δες
show
λίγο.
rows, πατήσεις edit rows. Edit rows και μπορείς αυτό να το αλλάξεις.
Μάτασε. Γιατί επεμβαίνεις? Ας τα παιδιά να κάνουν τη δουλειά τους. Κοιτάς, 1, 2, 3. Ωραία. Άρα τι μπορεί να είναι πάει το μυαλό σου?
Να είναι μόνο από τη μία πλευρά. Θα μπορούσε να είναι οικιακό.
Πολύ σωστά, μπράβο. All right, let's see the results. And I want to comment after the results from you, Liz. All right, we have the results from quantification.
Yeah, I think it's probably vascular on the right, because the left looks so normal. So I think it's a vascular problem affecting the right side and the left side is normal. So I don't think it's PD.
All right. Okay, let's vote and then we'll discuss it. And parallel, we're going to see the MR. Oh, what do we see here? Does this affect your interpretation? I'm wondering.
Είναι 3%. Πολύ μικρό το deviation. Ενώ στο άλλο που είναι παθολογικό είναι 60, 40, 50. Πού να δείτε το άλλο πρόγραμμα, που τα σχεδιάζεις μόνος σου, πολύ πιο βοηθητικό. Το άλλο το πρόγραμμα είναι custom made, γι' αυτό δεν ασχολιόμαστε καθόλου. Δηλαδή το έχει μόνο το Ιατρόπολης. Είναι τις ζήμες, το έχουν φτιάξει για το Ιατρόπολης, οπότε δεν έχει νόημα να κάνουμε training σε αυτό το πρόγραμμα.
Και το είπε ότι θα αλλάξει τα σχόλια. Τώρα στην καινούργια έκδοση. Θα το πούμε για το μαθαίνουν και τα παιδιά. Ναι, όχι, θα το πω. Ναι, έχεις δίκιο. Okay, 20 seconds, please, guys, vote. Show the results, yes.
Yes.
Okay, let's see the results in this one.
We're okay.
Okay. 75% thinks that pathological on right striata, and that's the correct answer. We can see clearly that in MRI we have a chronic ischemic lesion affecting the right striata. All right, let's pass to case number 9. All right.
Εδώ όλοι τα έχουν καταλάβει όλα.
All right, let's hit the question. Please vote in this very nice and easy case. Θα σου πω εγώ τώρα. Αυτό είναι. Okay, please vote. Okay, let's see the results from our first vote. Oh, 78% thinks it's a pathological on right striata and left putamen. All right, interesting. 38% pathological on right putamen only, and 70% that is pathological on right striata only. All right, normal, no one. Too bad. Okay, let's start quantification. It's patient
Number 7.
number 7. Yes.
Διαβάζεις αυτό που εκεί πέρα το
Τι διάβασα, τι είδα.
Ήταν 38 και είπατε 78.
Έχεις το τι έστερα και εσύ. 38, 58, 28, τώρα μαθηματικά κάνουμε.
Επίσης, είχες γράψει right striata, ενώ πρέπει right striatum. Όχι, όπα. Αποσυντονίστηκε. Όπα. Στο τελευταίο περιστατικό να δείξουμε και πώς παίζει ρόλο αν αλλάξουμε τα... ωραία, αυτό.
Νομίζω,
Σε αυτό.
αν θυμάμαι καλά, το 10. Αν θυμάμαι καλά είναι το 10.
Το τελευταίο, όχι αυτό λοιπόν. Εντάξει. Για να δείξουμε ότι μπορούν να το κάνουν και αυτό.
Κάνω το γρήγορα τώρα για να...
Μάλιστα. Ναι, κοίτα. Αποσυντονίζομαι, αγχώνομαι. Το παράκανε. Λίγο δεξιά.
Ναι, λίγο είναι πολύ.
Να το στρίψω. Αφού και σε αυτή το μία εδώ πέρα δεν είναι. Ναι. Δεν επηρεάζει και πολύ. Εντάξει.
Ναι, νομίζω είναι εντάξει. Ας το πώς είναι. Καλά, εντάξει, ναι, οκ. Όχι. Τον αριστερό. Εγώ νομίζω ότι δεν είναι αγκιακό. Εγώ νομίζω ότι είναι... Δεν κοιτάω καν εγώ να σου πω τα ζεσκόρ. Τα ζεσκόρ βασίζονται πάνω εδώ σε αυτή τη γραμμή και δεν είναι, για μένα είναι λάθος. Εγώ κοιτάω εδώ μόνο το deviation. Αλλά κοιτάω τις δικές μου τιμές, κοιτάω βασικά την αλήθεια. Αυτό το περιστατικό. Έχω εδώ και περιστατικά που θα έρθουν μέσα που με 11% είναι παθολογικά και με άλλα που είναι φυσιολογικά. Ανάλογα που έδωσε όλη την... Εγώ νομίζω ότι αυτό είναι προχωρημένο επειδή ή είναι πλάσ, ένα από τα δύο. Επειδή έχει την ασυμμετρία. Ένα από τα δύο. Ή είναι πλάσ. Πιο πολύ να σου πω την προσωπική ρeview που μου πάει για πλάσ.
Αυτό όπως θα έπρεπε να έχει πλαγιούς περισσότερο αριστερά,
Ναι. Για να δω τι σου έχει. Σίγουρα θα έχει πλαγίους αριστερά.
Μόνο
έχει υπερτονία. Μπορεί να είναι.
Με αντίστροφο pattern και ταιριάζει με πλάσ.
Εγώ σου είπα για μένα πάει για πλάσ. Δεν έχει το κλασικό. Απλά είναι, το έβαλα γιατί είναι confusing.
Ναι, από κάτω συλλογούν.
Ναι,
δεν μπορείς
και φουλακιακός. Αυτό είναι πολύ σύνθετο.
Και εγώ σου σκέφτηκα εδώ πέρα. Νομίζω ότι μπορείς να κόψεις. Ή είναι στην
Ενώ
πορεία
βγήκε για να το...
Οκ.
Ναι, all right. We will discuss this. Okay, Liz, I need your opinion on that. If you have an opinion.
Yeah, I think this time the left side is questionable. I think it's on the slide down maybe. So I think the right side is definitely abnormal. The left is low, minus 1.17. So I would be suspicious of PD in this case.
All right. Because it's the case of Dr. Leonardo's, if he wants to make a comment, and then we'll discuss this case.
Actually, thank you for the results because I haven't got them yet.
Live results today.
So this is a gentleman, 71 years old. His problems is actually the falls. He falls early in the disease course. He describes it like this: suddenly I feel something like a tendency to fall without understanding how I get myself on the ground. So this is a patient who has a very prominent issue with balance loss, with not your balance loss.
Your balance loss.
Our balance loss, with unsteadiness, with unsteady gait and early falls. Well, his clinical evaluation gives us an impression of bradykinesia, yes, with asymmetry regarding the left side of the body. That means that this gets very well along with the DAT scan picture we get here. So, yes, I could take the diagnosis of Parkinson's disease, but I believe that regarding his very early tendency to have repeated falls, I think that in 2 or 3 years follow-up, it will prove that it will be a Parkinson plus syndrome. He has not tried Madopar yet, so we're going to try L-DOPA and see how he responds. But I am afraid he will turn out to be a Parkinson plus.
I agree.
Regarding this asymmetry, which gets along with IPD.
I agree, because don't forget that we didn't say that only balance loss cases are plus. Okay, that's for sure. We can see a let's say similar pattern, but for my opinion, it's not quite the typical pattern of PD, this one. It seems to be. That's why I put this case. It seems to be, but not quite, because if you see again, βάλε μου αυτή τη μετατρία απλή σου πώς βάζουμε. Ωραία, βγάλε το ροή. All right. All right. If we can see this image again, we will see that if we check the background, I always say check the background, check the background. Maybe in TV or in your screen, in your computer, in your department, for sure the resolution will be better when you examine a Speg. I see enlargement in lateral in subarachnoid space. That's something that when I see it, immediately goes to something else than PD. I also see that the shape, it's not quite even pathological, normal pathological pattern. In PD, usually you see the non-affected area. It will be very smooth. The shape will be similar to that of physiological. Here, the lines are not the corresponding lines. Something else might be in pathophysiology in this patient. That's why I'm getting also to that direction, that maybe it's not PD, it's something else. That's my opinion.
Could it be DLB?
What? I didn't hear you, Liz.
Could it be dementia with Lewy bodies?
It could be, but
it could be.
He's not demented right now. But let me give you an extra tip, because I have the MRI results.
Excellent.
The MRI results, we are dealing with an extensive ischemic microangiopathy. He has Fazekas 3. And especially in the basal ganglia area, he has vascular lesions more on the right side.
Correct.
Okay.
Correct.
So that's
So
the
it's a
picture.
complicated
Yeah,
case.
yeah.
It's a complicated case.
I still, well, let me be honest. It's a case where L-DOPA response will be crucial for making the diagnosis, this supportive criteria I was talking earlier.
All right.
So let's find out whether
the
he's
future.
responding in the motor domain after we administer L-DOPA, but also we are going to be very curious to see if this L-DOPA administration causes some cognitive issues. So that would get very well along with what Lisa said about probably dementia. It's not a simple case anyway.
Okay, let's pass to the final case. You want to vote or not? You want to vote? Yeah, have the MRI. Yeah, very and cerebral atrophy.
Let's vote.
Let's vote rapidly. Now we
this,
know the answer on that. And to pass to our last case. Ne, Pam. All right. This is the last case. Please vote for this last case.
You can use the QR code on the left upper corner to connect with a Slido.
Till we finish the voting, I must add a comment in when you proceed to quantification with the Z-score. As Liz said before, the Z-score 2 limit, let's say, doesn't mean that everything we see in this area from 0 to 2, it's normal, okay? Always caution your interpretation. Maybe you will find that even in small deviations, you will see that it's in a pathological scans if all the other evidence, background, shape, all what we said are leading you to a pathological scan. Don't just see the values. The score is 1.8. Okay, it's a normal. That we're done. No, it's not like that. It's not that easy. Always check all those parameters we said in the presentation before. Quantification will be extra information, not misleading information to something maybe it's wrong after quantification. So be very careful with the normal values of that quant. All right? Check everything we learn. All right. Let's see the results in that last pathological on both putamen. Okay, 32%, close to normal, 28% and 25% pathological on left striatum and right putamen. All right, let's proceed to quantification. This one, the last one, it's case number 10. This is correct. 10-10. No. Το έκανες. We have a question from the audience. They say, can we conclude that we must rely on semi-quantification for our conclusion, even if our visual assessments show normal results? Interesting case. Interesting question indeed. As I said, visual assessment is your primary interpretation. It's your first opinion when you see a scan, but semi-quantification can mislead you only in cases in which values are quite to normal range. There is the tricky part. If you see deviation for 55%, 40%, it's a balanced loss case. You may think it's a normal, but it's not. So depending on the percent of deviation score, so sometimes you will find semi-quantification useful, other times you won't. So be very cautious on that, if I answered the question. Άλλαξες τα ροή.
Λίγο.
Ήθελα πρώτα, ωραία. Πάτα.
Μόνο το ένα putamen. Το ένα striatum. Το background το πείραξα.
Ό,τι θες μπορώ να σου κάνω, μα θέλεις.
Ευχαριστώ πολύ.
Ναι, πρέπει να το βγάλουμε τόσο τέτοιο. Alright. Liz, this one.
Το background το πείραξα.
Γι' αυτό δεν
Um,
να το πειράξω.
Tricky one again. Can you show me the putamen to caudate ratio, please, on the plot? Yeah, so the right side is showing that the putamen's down, which it looked like visually. Left seems to be sitting normal. It's a tricky one again. You've selected difficult cases.
That's the goal, I think, right?
Yeah, it was.
All right. So in this case, indeed, I don't have any other information to give you. No MRI, no any other clue from a physician. So what do you think? We will vote, and then we will see what's my opinion and your opinion. Okay, let's start voting, and then if you want, we can discuss it. Start voting. Δεν έχει επόμενο. Αυτό, ναι, voting. Okay, let's vote. For this last one, nice case. What I see, from my opinion, in this visual assessment, just to discuss it. First, I see enlargement of subarachnoid space in general in the brain. I don't know if it's starting some atrophy here, maybe not. Also, slight enlargement in lateral ventricle also may affect our image. Something that confuses me in this case is that the increased uptake in right caudate compared to left caudate, something again that confuses me. Maybe we have also some pressure from something anatomical, and maybe this is a normal scan in the end. It's all indeed it's tricky. It's a case, if I remember correct, from last week from my department, and still remains unclear. We will talk it with a physician to figure out what we have more as information to establish a correct diagnostic in that case. But it's true that this is a very tricky one. One thing I wanted to show you in this case, that quant in automated positioning of the background, due to the fact of atrophy, gave a low ratio of background and increase the SBR. So
Yeah.
so we corrected and we put it inside, little inside the brain, and the values then corrected, and it shows that only let's say minor decrease in uptake in the left putamen, and might increase uptake in right putamen, and in right caudate increase. So these are some things that are confusing me in my final report. Maybe I will discuss it with the physician before I give it, or maybe I'll try to give it normal and we'll see what happens. I don't figure out.
I was going to mention that about the background. I thought in this particular case,
I
there
put
is
it. I put it
reduced
more for
uptake.
this case. I put this for background. Check
Yeah,
the background.
yeah,
If the patient has atrophy, change where you
yeah,
put your background. All right?
yeah. On just a comment on
Yeah.
Excelerus 4 that you're working on there. This is an older version of DATQuant. The new version on Excelerus 5 and the standalone version allows you to easily move the background. I
No.
don't think you can do it on this version. Yeah.
Oh, and this version also you can change it.
Oh, can you? Okay.
Yeah.
Okay.
All right.
But I know in 5 and standalone you can definitely.
Ah, okay. In my the version I have in my department, we can change the ROIs in background
Yeah.
also.
I
Okay.
have a feeling when they earlier on one of the other scans they
What,
check the
Liz,
ROIs.
what I
Yeah.
want to say is that neither version can change the rotation of the ROIs. That's a tricky
No,
one.
no. You can't rotate at all,
Yeah.
no, and you can't change the size.
Yes.
Ναι.
Yes.
Yeah.
All right. I think we're done. If we have any other question from the audience here or from the participants, we can close our. All right, 55% thinks they're normal. Could be. It's a tricky one. Neither I can.
50-50%.
Yeah, neither I can give you a straight response at this time. All right. Okay. Thank you very much. Now, so
Thank you for your time. Thank you for your consideration. Thank you all of you that remain very active until the last moment of this workshop. And please consider to make a registration in order to have, or if you already registered, you will have the possibility and the option to have these interesting cases and all of the presentation on demand next week. So thank you once again, and let's see you in the near future. Okay, thank you, bye-bye.
Thank you. Bye.
Ωραία. Υπάρχει ένας μικρός μπουφές ακριβώς έξω από την αίθουσα. Μπορούμε να περάσουμε τώρα στο μπουφέ.